good afternoon, good morning, good evening, depending on your geographical location. I am Yağız Üresin, Vice Director of Istanbul University Center of Excellence for Clinical Research. And I would like to welcome you on behalf of myself and our Director, Professor Tufan Tükek, who is the Dean of Istanbul Faculty of Medicine as well. And welcome to our meeting called Grace Under Pressure. And for the name, I should like to thank to Ernest Hemingway and actually the Canadian rock group Rush. So the title explains itself. I don't need to talk too much about that. It's about conflicting and controversial results in COVID-19 clinical trials and how to generate reliable knowledge in the middle of this infodemics. And I would like to thank to my university. I would like to thank to our network, International Clinical Trial Centers Network. And I would like to thank to Dr. Club, the guys who make this broadcast possible. And we have just a housekeeping note. We have two discussion parts as in the program. So you can ask your questions whenever you like by clicking the Ask Question button. I don't have the button, but I guess you have that button. And you can describe which speaker you are addressing, and we will see the questions. And I will ask those questions in these discussion parts to the related speakers. And with that, I would like to pass the floor to Thomas F. Hiemstra, who is the chairperson of the International Clinical Trial Centers Network and the director of Patient-Led Research Hub at Cambridge Clinical Trials Unit. Thomas.
Thank you very much, Professor Üresin. It is a great pleasure and a privilege to be with all of you today. On behalf of the ICN, thank you very much for the invitation to participate and support this very important meeting. It's a fantastic program and a fantastic lineup of speakers, and we're very much looking forward to hearing everyone's views in what is really a most important time for us as researchers. Seminars are always important learning opportunities, but never as much as it is at the moment. It has, for many of us, I think, been the most challenging time of our professional careers, and we have faced some real difficulties and challenges, and it is absolutely crucial that we come together to learn from each other and to try and map out how we deal with a similar situation in future if and when it arises. So I'm looking forward immensely to hearing from colleagues at this very important time, and I hope that we can have a productive time and learn together. And thank you again to the organizers for making this extremely important meeting possible. With that, I would like to hand over to our first speaker, Professor Ahmet Gül, Professor of Medicine and Division of Rheumatology at Istanbul University. Thank you.
Well, thank you, Thomas. Thank you for the invitation. And it's really a great pleasure to start with this great meeting. This is actually an introductory talk, and I would like to summarize our knowledge about COVID-19, which has evolved within 6 months' time. So can I start with my first slide? This is my agenda. Actually, my agenda is composed of Hippocrates aphorisms. The first part is well known by many. Life is short and the art long. But the remaining part is usually not known very well. It continues with opportunity fleeting, experience perilous, and judgment difficult. So this is my agenda, and I will try to summarize the findings within this topic. Okay, life is really short. We have been observing COVID-19 pandemic, which is probably would be the first one, and hopefully would be the first pandemic that we have ever seen in our lifetime if we ignore HIV. And this is the current situation of the pandemic. Now, more than 24 million cases, and the death toll is over 830, and it's covering all over the world. And the whole story actually started at the end of last year with an official communication between Chinese authorities and WHO authorities about a new pneumonia, possibly viral pneumonia, identified in Wuhan. So after this communication, data gathering has started, but it wasn't actually a shared information for some time, many weeks. And later on, we have learned that it's actually communicating within people. So it is being transmitted from human to human. And it's not only limited to Wuhan, certain part of the world, it's actually spreading to other cities of China and also neighboring countries or even distant countries, possibly by the asymptomatic cases, which was not known at that time. And still we have been discussing whether it started in the seafood market or it is actually produced within the laboratory. Actually, it's not really necessary to know these details, but it started at the end of last year. And when we have gathered some information about this novel coronavirus, well, it was a new one. And this publication is from February 20th February of 2020 from New England Journal of Medicine. And if you look at the editorial of this paper describing this novel coronavirus associated with pneumonia, the case fatality rate was unknown. Whether it is a pandemic or not was unknown. And could it be contained? Well, there is no sign of containment, but there were efforts to restrict its spreading. And there were some similarities to especially previous pandemics or epidemics of SARS and MERS, which were actually much more regional compared to now the new COVID-19. So if you look at the timeline of WHO, well, they collected more information, they shared the information with other countries, but they declared the pandemic very late. The declaration of pandemic happened with a press release on 11th of March 2020. And in their description, they mentioned that in the past 2 weeks, the number of cases of COVID-19 outside China has increased 13-fold, and the number of affected countries has tripled. There are now more than 118 cases in 114 countries, and more than 4,000 people have lost their lives. And based on these findings, they were quite hesitant to declare pandemic. And if you look at their sentence, we have therefore made the assessment that COVID-19 can be characterized as a pandemic, mainly because of their worries about declaring something wrongly, because they continued their declaration as pandemic is not a word to use lightly or carelessly. It is a word that, if misused, can cause unreasonable fear or unjustified acceptance that the fight is over, leading to unnecessary suffering and death. Well, actually, it caused a lot of deaths, and these delays played a really critical role. As I mentioned, it is a newly emerging disease, and for our lifetime, which is short compared to human history, well, there are many things we do not know. As a new disease, there is no reliable data about its main characteristics or its disease course. No known treatment, no vaccine. What we have learned in the meantime is a previously unknown beta coronavirus. It's different from MERS-CoV and SARS-CoV. And at that time, it was named 2019 nCoV, now named SARS-CoV-2, as a seventh member of this family, which can infect human beings. Okay, if we look at the history, this is the history of pandemics. Thanks for the website, Visual Capitalist, which is summarizing big outbreaks, big pandemics. And the last one is appearing HIV epidemic or pandemic, although it was a bit different, a bit slowly spreading condition And maybe the best example that we are suffering now would be Spanish flu. But with the numbers that those we have now, similarities can be made also Russian flu, Asian flu, or Hong Kong flu. But it is definitely one of the pandemics, and throughout the life, we gathered a lot of information from this pandemic. So the human being has actually a capacity to deal with this pandemic, and it is more beyond our lifetime. And if you look at this experience, well, the prevention of spread and reducing the risk of outcomes is quite critical. And especially non-pharmaceutical interventions played a critical role there, quite effective. And many countries had some hesitation to apply these interventions. And especially nowadays, it's been discussed, is there any evidence to use, let's say, face masks or isolation? And it's really necessary to lock down. Well, do we really need updated evidence? This is the picture from Spanish flu, and this is the picture from Wuhan, and you can see the similarities. This is the picture again from Spanish flu, ladies producing face masks, and this is a picture from Turkey. The army personnel is producing face masks. There are many similarities. It's exactly the same situation. And if we really need data, well, data is coming, although it may be a bit late, and we may have lost lots of lives. And when we evaluate the non-pharmaceutical interventions' success, they are effective, although there may be some country-specific changes in the efficacy of different interventions. But if you look at the recent Nature publication, this is the situation where there is no intervention and the infection growth rate without intervention policies. You can see the expectations. And this is the effects of all policies combined in different countries. It may include emergency declaration, travel bans, home isolation, closure of some religious places, or prevention or banning gatherings or social distancing or face masks. I mean, they are really effective non-pharmaceutical interventions. And since it's really an emergency situation, I think that the second part of my agenda is opportunity fleeting part. Well, we really have a time restriction. It is an emergency situation, and it's necessary to act fast to be able to save lives. So we have to interpret all available data in a very short time. And within this period, we have some experience coming from SARS and MERS, and also from other common cold coronaviruses. There are 4 common cold coronaviruses which are really recurring each year, and it's causing mild cold symptoms. It's usually affecting the upper respiratory tract. Pneumonia is really an exception. And there are other examples which are much more similar to COVID-19, especially SARS-CoV-2, with a range of asymptomatic to severe pneumonia, and replication of the virus throughout the respiratory tract, especially the lower respiratory tract. MERS is also quite similar to this one. There may be some subtle differences with less upper respiratory tract infection. But if we look at the immunity developing against these coronaviruses, again, for the common cold one, it is short duration, therefore it is recurring every year. But for the SARS and MERS, it lasted about 2 years. Or maybe more. And based on this experience, everybody thought that, okay, if it is like SARS, it may last at least for 2 years, and there may be somehow 2 or more years lasting immunity. And most of the observations that were actually depending on the humoral immunity, the antibody responses. But later on, we noticed that there are many asymptomatic cases, very similar to the experience in SARS. And these asymptomatic cases are actually having no disease manifestations, despite this is totally new disease, newly emerging disease. So how can we develop some sort of immunity causing this asymptomatic course? And later we noticed that, especially if you check the cytotoxic immunity or cellular immunity in CD4 and CD8 T cells, there are some overlapping epitopes between SARS-CoV-2 and the common coronaviruses. So maybe the common coronavirus infections are somehow producing some cytotoxin overlapping protection for the COVID-19 without producing a humoral immunity. And also we had some experience about disease course, which is causing a hyperinflammatory response, especially in patients with SARS. And this hyperinflammatory response was resulting from imbalance between the early interferon response and the later innate immune activity triggered by these viral infections. So despite the acute and controlled viral infections in some patients, some of the patients, especially those with a fatal course, developed a hyperinflammatory response, mainly due to either viral overload or some host factors causing a very severe innate immune response, depending on late adaptive immunity, late interferon response, and the continuation of these processes, which at the end results in tissue damage. So if opportunity is fleeting and if really we have limited time, we have to share all available data and clinical experience as early as possible with our colleagues and with public, with health authorities. Therefore, most of the journal editors encouraged authors to submit their work for posting on preprint service. Well, that's actually not a common practice in medicine, although it's been happening in other disciplines, especially in computer sciences and social sciences. But for the first time, we have encountered this preprint service, which was actually full of papers, not proofreaded, not evaluated by editors or our colleagues. So it might be regional, like China Archive, or it might be more widespread, like Med Archive, but we had lots of papers submitted to these preprint servers before being evaluated in a journal. And for the journal process, a rapid evaluation of manuscripts and expedition of editorial steps were promised by editors, which resulted in a flood of papers. So it was really a tsunami of papers when that was not an experience, again, we had previously. So if I have to make a tribute to the rush that we share the topic of this meeting, so it was like a gold rush, but this was a paper rush. Very similar to gold rush, there were many investigators trying to publish their study. So it was somehow easy and fast process, especially in high-ranked journals. And for the editors of these journals, it was a possibility of high citations. But unfortunately, very similar to gold rush, when you continue this process, it's mainly pebbles and stones. So there were only few gold data. It was quite hard to find reliable data among these lots of different publications. So within this gold rush, we had retracted papers from very high-ranked journals. For example, this cardiovascular disease, drug therapy, and mortality paper appeared in New England Journal of Medicine, was retracted based on the unreliable source. And very similarly, the same or the shared authors published a paper about hydroxychloroquine and chloroquine and its effect, especially on mortality in patients with COVID-19. And that paper was also retracted. And if you look at the content of these papers, well, it was really quite hard to be accepted by these journals. So it was really quite hard to understand how the editorial process progressed to this step, especially the last paper is coming from cardiologists or cardiac surgeons. Probably none of them had seen any single COVID-19 patients that had no information about the hydroxychloroquine, and there was no source that they can rely on about the international collaboration, but these data were published. So we had problems. And all this experience showed us that experience is usually helpful, but experience may also be perilous and misguiding, and the judgment is really difficult. Because we had problems in developing new treatments and vaccines, It's a very short time, and we have to use available antivirals, or we have to repurpose some of the drugs based on the in silico information, or we have to add some other methods to deal with the symptoms of the disease, such as anti-inflammatories or anti-cytokines or anticoagulants. But when you look at the information, there were many problems in designing or running of clinical trials, mainly due to short duration of pandemics. So you have to run something in a very short time. There were problems in patient access and monitoring. It was quite hard to collect data. And there were problems in the definition of standard of care. There is no standard of care, actually. But when you are comparing a certain drug with standard of care, there were many problems, and there were also problems in the outcomes. If we look at the hydroxychloroquine example, there were in vitro data supporting their antiviral activity for hydroxychloroquine and chloroquine, mainly due to the prevention of viral entry into the cells and its prevention within the cell, the prevention of replication. And there were some experience from SARS and other viral infections, and it was cheap and relatively good safety profile in rheumatic diseases. However, because of the dosage it's been used in SARS-CoV-19, the high dosages was associated with cardiac toxicity. So that was one of the problems. So the dosage was an issue. And despite all of the information that I will share with you, the final word has still not been said for especially post-exposure prophylaxis in outpatients. The early experience came from China with good data both for hydroxychloroquine and then the hydroxychloroquine. And in France, they reported a favorable outcome for hydroxychloroquine and azithromycin combination. And there were also some contrary information about the use of hydroxychloroquine in other sources, especially it may be associated with worse outcomes. Well, you know, can we really produce evidence strongly in such a short setting? We are all believing that there are hierarchies based on these evidences we are collecting from either open label trials or randomized clinical trials or their, let's say, systematic reviews. But it's really quite hard to design and run randomized clinical trials. And are all randomized trial data reliable within this period? Well, we can have the example of Recovery. Recovery was really a quite successful setting developed in the UK. They produced a data for hydroxychloroquine, and they showed that the hydroxychloroquine is not working in hospitalized patients compared to standard of care. However, if you look at the early outpatient or post-exposure prophylaxis data, there is one randomized clinical trial data coming from Canada, but I mean, there are many problems in their design. So the exposure data is reported by participants, and if you look at the event data, which was reported in 113 patients, only 16 had PCR confirmed coronavirus infection. So, well, within this information, it was impossible to be accepted for publication in the New England Journal of Medicine, but that was published. So can we really rely on this data? Therefore, there are a few studies still continuing about the outpatient and also post-exposure prophylaxis use of hydroxychloroquine in these settings. And within this period, we have only one strongly positive data, which is not an antiviral data, which is an anti-inflammatory data, dexamethasone use in patients who are receiving mechanical ventilation support or oxygen support compared to standard of care. But this positive effect could not be shown in patients needing no oxygen support. So in patients with a more refractory or with more respiratory course, some anti-inflammatory effect can really be helpful in the prevention of bad outcomes. So I will finish with William Osler. I started with Hippocrates, and this is my last slide, and it's based on William Osler's talk for the finish of the last day of a medical school, Pennsylvania medical school students. And he suggested the students the word which has been described by Pius, Antoninus Pius. And when he was at deathbed, his last word was equanimitas, which is equanimity. Well, in short, it is imperturbability. And Osler suggests that in the first place, in the physician or surgeon, no quality takes rank with imperturbability, which means coolness and then also presence of a mind, let's say, under all circumstances, calmness amidst storm, clearness of judgment in moments of grave peril, immobility, impassiveness, or to use an old expressive word, phlegm. So we really need imperturbability in this difficult situation to be able to read all available information correctly and to interpret them as it should be, and to help our patients to save their lives. Thank you very much for your attention.
Thank you very much, Ahmet, for this enlightening presentation. And we move on to the next speaker, who is Betül Baykan, Professor of Neurology, and she's the head of the Department of Neurology of our Faculty of Istanbul Faculty of Medicine. Yeah, the floor is yours, Betül.
Hi to everybody. First of all, I would like to thank dear Yağız for inviting me to this very interesting event. I will talk about the challenges of research in the pandemic era. Actually, an introduction is not needed because everybody is aware of it. We have an idiom in Turkish, even the deaf sultan has heard about it. The problem is we have no information about this disease. These are my subtopics. I will talk about the lack of reliable information, about the COVID-ization of research, prevention measures, and I will have some conclusions if there are any. Even the diagnosis of this disease is problematic. There are many cases without any definite laboratory confirmation. They could be diagnosed with lung CT and so on. So this is a problem too. I'm a neurologist, so my examples will be based on neurology. The neurological side of COVID-19, there are many possible hypothetical mechanisms like an indirect effect on the CNS, direct CNS invasion, post-infectious or immune-mediated causes, or other causes. My example will be Guillain-Barré syndrome, which is a rare acute demyelinating polyneuropathy. Though the GBS is rare, it's well known. It emerges after a multitude of infections like flu virus, Zika virus, or other coronaviruses. And studies have shown an increase in the data after flu pandemic. And so there is a possible connection. And the first anecdotal reports of GBS in relation to COVID-19 came from many countries. However, though there is a clear clinical suspicion, there are open questions for research. What are the chances that someone gets GBS during or following COVID-19? Does GBS happen more often in these patients infected with COVID-19 compared to other viruses? Or are there any differences from a clinical point of view, like there are information about facial involvement? Could it be prevented and how? There are many, many questions, and they could only be answered through a prospective study. And there are some studies we have to wait now. There are also speculations on the neuroinvasive potential awaiting confirmation. We have some previous models about structural similarity and sequence homology, and we have some hints for potential entry routes, but we don't have now the best model and we don't know any ways to block it. The pandemic has clearly negative effects for researchers, like fear of catching the virus, fear of passing it to family members. They have long work hours, some doctors, and there are deployment to other work locations, pay cuts, lack of institutional support in some countries, or they have to work from home without childcare and so on. There are many, many stressors for the researchers and physicians. Also, from a patient's point of view, there's a lack of information, conflicting information. Social media causes really horror and misbeliefs, and there are rapidly changing policies. So this prolonged exposure to the stressful situations can result in psychiatric conditions as well as dysfunctional coping mechanisms. Infodemics. What is infodemics? It's overabundance of information, some accurate or some not, that makes it hard for people to find trustworthy, reliable information. There are many rumors, stigma, conspiracy theories, and so on during COVID-19 pandemic, as we all aware, and health agencies have to prevent this, really. There are also studies on this, and there are very, very much bad rumors and stigma and so on. An example again, ibuprofen story. In March 2020, the French authorities warned against the use of ibuprofen in patients with COVID-19. It is based on a report of an infectious disease specialist on only 4 children with COVID-19 whose conditions was worsened after ibuprofen. This resulted in a recommendation to avoid ibuprofen by World Health Organization. Actually, in pre-COVID times, this type of evidence could be only anecdotal or if considered at all. Actually, there was a hypothesis, a viable hypothesis suggested that ibuprofen increases ACE2 possibly via inhibition of COX activations and other ways of activation. Afterwards, WHO retracted their original statements. Also, European Medicines Agency stated that this data is insufficient, really. And now, what have we do? Could we use ibuprofen or not? Actually, there is a new paper appeared showing that in a large prospective cohort, over 300 persons, ibuprofen was not associated with a worse clinical outcome. We have to wait more, I guess. And another problem is COVIDization of research. Everyone is COVIDized, and this should worry us. There are dangers. Everything is being put into COVID research. Funding agencies have done this at the cost of canceling and delaying regular open competitions. For example, our university's research fund, we have canceled one priority call and favorites another target hunting call for COVID-19 projects. Journals are dealing with too many submissions on COVID-19, and the media is interested only on research about COVID-19. There are a sense of urgency which might come at the cost of careful discourse and scholarship. Actually, this urgency and COVIDization makes sense because research is desperately needed to fight this pandemic. But normal scientific progress seems hard to justify in the middle of crisis. Indeed, crisis-driven such approaches have led to some successes in the past. We may remember Ebola or AIDS crisis leading to some therapies. I'm a clinical neurophysiologist, and I have to say that there is a problematic signal-to-noise ratio. There is so much noise that everyone is struggling to separate signal from this noise. Ahmet has mentioned this flood of retracted research papers, which means lowering of normal scientific standards. Bad science combined with poor science communication is eroding public faith in science and research, which is another problem. Another important point is that well-intentioned scientists with real expertise in one field intrude into another. For example, In the field of tuberculosis research, many researchers have now pivoted to COVID-19. This is a loss, since tuberculosis is the leading infectious killer and is getting even worse because of the pandemic. So we have to avoid this full COVIDization, and some researchers should stay focused on their primary vision, even this is not attractive at the moment. If not, the collateral damage from the pandemic could be more devastating. And we hope to believe that humanity has endured many crises over centuries, and COVID-19 crisis will also pass, hopefully. We need a long-term vision and strategy for research scholarship, and we have to think about it that short-term crisis-driven thinking is neither strategic nor sustainable. So we have to be thoughtful about the risk of this COVIDization, and we shouldn't forget that diversity in research is critical. What about the prevention measures? We know the risk for asymptomatic carriers. It's really a problem. And there are many measures that we have: wash your hands, keep a distance, and so on. However, even simple things may cause disbelief. For example, there are rumors about using masks are useless, or masks are even harmful, creating hypoxia and so on. Yes, these masks are uncomfortable, this is true, but there are sound reasons to follow the recommendations. And by wearing a mask, patients are reassured that you are taking them and this pandemic seriously. And we know that there is a clear mortality rate increasing with age. This morning, we have discussed with my dementia staff that we have to temporarily close our Alzheimer's clinical research unit and reopen it as a neuro-COVID unit, at least for some time. It is true. How could you invite your elderly patients or immunosuppressed patients to a research-only way? How could we continue our clinical research? We even stopped our migraines research project in 2/3 of the target population in order to minimize the risk of contamination for the patients in the public transport. Are there any opportunities? Well, yes, literally, this is an opportunity. COVID-19 is helping to develop telemedicine, which is indeed very practical for the moment and will also be fruitful in the future, I hope. A safe way to study human data during the pandemics is surveys, I think, and we have implemented a survey related to headache characteristics of COVID-19 related headache, and the response was huge. There are over 3,000 responders to our survey, and we have to be able to extract some important COVID-19 related headache features with a high range of statistical safety, and we have found some important headache triggers in some of the groups and so on, and published this data. So in conclusion, we scientists should continue to work. Science has many enemies. Working and publishing in science means rigorous rules, following rigorous rules to find the truth. But a problem inherent to science is that we don't know in the beginning what is true. A good scientist is the first one to concede that she is wrong, maybe. There isn't any single construct of the truth that survived the ages, and there is always a never-ending battle between the good and better ideas. And today's current up-to-date idea is tomorrow's error of yesterday. If you ask me how to conduct research in a pandemic, I have to say I don't know the answer. But Karl Popper, an important health philosopher, mentioned that a scientific theory must be falsifiable, and scientific knowledge is always tentative and conjectural. He says also science progresses by means of risky predictions and results that are unexpected, surprising, and sometimes spectacular. The key is sobriety and reliability. In conclusion, COVID-19 pandemic has significant negative effects globally on public health, the economy, and so on, and it has placed great pressure and stress on the research. Every crisis is a strong call to mobilize the entire research community to respond, and researchers definitely deserve support to control anxiety and depression, and also maladaptive coping mechanisms. Thank you for your attention.
Thank you very much, Betül. Now we move on with Atahan. I see he's ready. He's showing his profile to us. Atahan Çağatay, he's a professor in Istanbul Faculty of Medicine, Department of Infectious Disease, and the title of his talk is going to be Turkish Experience in COVID-19 Research. Yeah. Sesini aç. Okay.
Hello everyone, dear President, dear Professor and respected attendants. I would like to thank Professor Ürizin for inviting me to speak before you. My name is Atahan Çağatay and I have been working in Istanbul Faculty of Medicine, Department of Infectious Disease. And this hospital is where the first two COVID-19 cases have been diagnosed in Turkey. So it was highly important at that moment for knowing whether there was a COVID-19 case or not in Turkey. Now I'm trying to talk about what happened in Turkey in terms of scientific research and what could have done so far. At the beginning of the pandemic, we, Istanbul Faculty of Medicine, has been assigned as one of the pandemic hospitals in Istanbul eventually. So I would like to give some impression I had from the pandemic across the world and specific to Turkey. Now, what did we have in our hand against pandemic as Turkey before it had started? Especially China experiences, like everyone before it has reached to us. Of course, we managed to follow what's happening around China and some countries where their cases have been seen. Happily, we found out many data about the new coronavirus and COVID disease from the literature, including most of the patients from China. Yes, we are seeing that toll and it is on the rise. Unlike other specialists, I have to be in. And yes, we had some expectation that the pandemic should be caught itself at some point. But now it was on the rise and still rising. And the other point that the lack of personal protective equipment and the beginning of pandemic, we suffered some tough time to find mask, face mask, body suits. Later than we had them thanks to our health authorities and those who donated. And the other point that lack of scientific materials, actually we have some basic scientific data, but in every day they are prone to be progress and be hidden and be changed. And the last one that lack of our colleague next to us. Yes, this paper has been published at the onset of pandemic. It has summarized all happenings in the course of pandemic. Since initial cases were reported by WHO on January 5, 2020, that around 60 suspicious cases were detected between December and January in the People's Republic of China. And this has been followed up by the public health authorities in our country. They have been closely monitoring the developments all around the world. And they, I mean Turkish Health Minister and its subcommittees, they formed and put a team together to work on continuously, and they establish a scientific board for COVID-19 at the Public Health Emergency Operations Center within the public health authorities. What is the scientific board? Who are the people that consist of scientific board at the same time? They consist of several groups of people. Most of them are specialists in infectious disease, pediatric infectious disease, chest disease, ICU, microbiology, virology especially, and some are from the public health, and some are legal counsel. So health minister and its subcommittee being assigned, put a scientific board together to take responsibility. A scientific board for COVID-19 conducted for our country COVID-19 risk assessment and COVID-19 guideline and case report form was prepared in the same group, by the same group. And this is the publication made by this the scientific board. Like everyone in our country has faced this virus and pandemic caused by itself at the same time. I meant that in addition to negative aspect of topic regarding what decision a scientific board should make, that some reflex would be weak and lack of information and debatable issues such as hydroxychloroquine plus azithromycin and antihistamine therapy as well have been trend topic between us at the same time as in the rest of the world. From the beginning to date, I take this approach of Turkish Health Authority to pandemic positive. I still stand for my point of view how to manage the pandemic. By the way, health minister and health authority put some algorithm for all physicians, nurses, and other assistive health team to employ it. As we believe that all medical levels are not the same in every place, in any city or any country. So this document showing algorithm seem to be much better to reach them. Meanwhile, any panic that could be arise in the public might be possible in case that will be a rumor related to any drug which could have benefit of COVID. So this kind of administration of pandemic, such as one hand, is of high value to manage it. I'm positive about this approach. Honestly, I can say that Turkey has never faced such high death toll in the course of pandemic so far. What I want to emphasize in this stage is that if there is any success in this point, we should give the right to those who gave contribution as health authorities, in addition to those working in the hospital, examining all patients directly. Now these documents have been published and they are related to guidance to outbreak management and working. As I know, they are available to promote day by day. And as compared to other countries, in terms of the documents, most of them have not been prepared in the names of health minister. Generally, some institutions, some medical schools, such as Protocol of Harvard Medical School, some societies, such as IDSA, ASMIT, had done it. And honestly, I can talk for myself. I tried to follow all this protocol, and at the same time, the protocol prepared by our health authorities. And according to the guide, as you can see on the slide, showing some drug suggestion for PCR positive asymptomatic patients. And in this slide, it shows that what different drug we add to general treatment as compared to other countries' treatment list. As in Turkey, all these drugs being given by the health authorities have every huge experience for us. And I mean, I want you to imagine for a while, you have more than 250,000 patients with PCR positive, and most of them, almost all of them, had taken these drugs to date. So it is inevitable that you had huge impression about how effective these drugs would be, what kind of sensitive point about adverse effect. As I told you before, this administration strategy might have right side and downsides as well. I would like to stop here by telling last word about positive side of having ability to give something are better than waiting without giving anything and then just talking. Now here is the slide, some other suggestions to patients with severe pneumonia hospitalized. And similar offers for the patient with severe pneumonia. And what about the drug supply and limitation and PCR tests in Turkey? And some details about medication will be brought at the second part of the conference, I think. Until recently, I meant up to last a few months, all patients who were diagnosed as COVID-19 were given azithromycin plus hydroxychloroquine. At the beginning of the pandemic, favipiravir was being given when the patient were just in the ICU. Later then, we had contribution with some suggestion to the health minister that this antiviral drug, favipiravir, should be used in inpatient wards and later even outpatient in addition to ICU. And last development in this topic, health authorities started giving favipiravir outpatiently and especially in patients with mild to moderate pneumonia, with the decree being taken 20 days ago. Now, all these regulations have not also been limited by just therapy supply, but also take PCR tests. Some authorized laboratories have been assigned to the lab center to take these tests. All primer substance for PCR and what are necessary in employing this test were supplied and have been supplying by means of government. And it's the committees and the public health authorities, we call it the general directories of public health. And at the same time, I have to say that no private lab could not take this test at the same time. Now, when it comes to science and research, I want to show this website. It is TÜBİTAK, the Scientific and Technological Research Council of Turkey. Researchers the group in this slide in the three sublines, and as in every countries, like every scientist, a number of researchers gave many projects to discover new methods to make the COVID diagnosis as early as possible. Now PCR methods working with saliva or other sample within shorter time than expected, and some artificial intelligence projects which are able to diagnose the virus over some software. The therapeutic agents are not at the optimum level. It was thought that some drugs that are not at the expected level, we need to see some new molecules in which we are working on seem to be promising. As I know from my colleagues and their projects aiming at protecting the human being from the virus and making this virus ineffective. I hope that one of them would be real. And the other, the subcommittee, the TÜSEP, the Presidency of Turkish Health Institutes, is a subcommittee of health minister, developed the project by the clinical trial. What about the vaccine? As I know, there are the two different research groups in developing vaccines against the SARS coronavirus 2 in Turkey. As I learned that one of these vaccines reached to the phase 3 clinical trial. Now, this website includes some images that stands for its meaning. And this image is related to the TÜBA. It means Turkish Academy of Science. TÜBA is an academy which the professor gives a member of it. And this academy published a report regarding the COVID-19 global outbreak. And here is another books produced by the same the group. And here is the slides include some the news, an announcement about the conference. This conference was about the COVID-19 Turkey platform to develop vaccine and drugs, and it was held at April 2, 2020. So it has been started like every country is on it. And another conference was about the topic in developing genomic map center. It has been held in Izmir, Turkey. And here, this website belongs to TÜSEP, which means the Turkish Health Institute. This institute supports all researchers who have projects on COVID disease. Now, you can see some column in this the website. This website lists some scientific project and show its contents. Here is a line including diagnostic centers and their projects. And here is the column shows that the clinical trials about the COVID disease and the viruses. And the other one is the projects and educational the supports. And the last slide, when it comes to science, when we have to talk about the medicine, I need to keep their memories alive once more. Yes, we lost them, but their memories, their monuments will be living among us for life. We lost our most precious one. I'm memorizing them once before you. They are of great value for me, for us. Thank you for your attention.
Thank you very much, Atahan, for this comprehensive talk and to reminding us to those who have lost. And now I'm coming to the last talk of this Istanbulish session, which is mine. But before that, I want to tell you something. This is not my office, okay? I know that some of my international friends are surprised. This is the office of the Vice Dean of Istanbul Medical Faculty, which brings memories of my father back, who grew up at the beginning of the 20th century, at the first quarter, actually in a nice place of Istanbul, but back then everyone was poor. So if they had an important guest, any family, actually they hosted that guest in the house of the wealthiest family. And I felt like that because we have important guests here. Our administration gave me the opportunity to host the guests in the office of the Vice Dean, which doesn't necessarily match with my taste, actually, but I would like to thank them. Now, this is my presentation. This is who I am. And I am lucky that most of what I want to tell has been already presented, but I would like to start with an observation. A couple of months ago, I was watching a webinar like this by the European Society of Cardiology, I guess, and there was a discussion about the number of stroke patients in a Dutch emergency station. Barbara Cassidy is a cardiologist, and she's obviously Italian. And Bart van der Worp, he's Dutch, and he's a neurologist. And she was interviewing him, kind of, and she asked him about the apparent decrease of the number of stroke cases in Holland. And she said, what are the lessons to be learned? And she ended the question with the phrase, what do your data show? Which I find very significant. And his answer was, in summary, he said, of course, he had some technical answer, but which was important to me was, the lessons learned will come later, after a few months, maybe a year. And then we will know what we have done wrong, what we have done right. Of course, for us, for researchers and clinicians, etc., this is kind of usual. But if for the public, it's strange. I find you do something, you apply some treatment, but you don't know if it is wrong or right. But this is the truth. And by the beginning of the last century, we had this actually US flu, which was called Spanish flu. And this is the most effective precaution. And now we have beginning of the 21st century, this COVID-19, and more or less the most effective approach is hygiene, actually. We have to be frank, no disease or no outbreak has been solved so quickly, and not with pharmacological interventions, at least at the beginning. So developing a vaccine or a drug takes 10 to 15 years. Fastest developed vaccine was mumps vaccine, which took 4 years, because there was the possibility to use existing results from related studies. And hepatitis C virus was identified in 1989, and direct-acting antivirals were approved in 2013. HIV was isolated in 1983, but there is no vaccine, no definite cure. Antiretroviral therapy regimens increased life expectancy in the last decade, but the research is ongoing. And how long does it take to develop a vaccine? Actually, too long. Here you see some examples. So actually, our expectations are a bit too high, and I find we are not doing very bad. Actually, talking about vaccines who will reach the market, say, in almost 1 year after the starting of the outbreak. But we should have some patience. But there are needs. As of 26th of August, we have 24 million confirmed cases and over 800,000 deaths. There is huge amount of socioeconomic effects and a massive pressure on healthcare system, and it's a public health emergency of international concern, of course. There we have the pressure of our title. And there is a rush on publications and trials and data sets. I don't need to explain them, everyone is aware of this increase. But they are not necessarily in search of the truth always and in search of cures, but some of them at least are just for the sake of publishing. And in our Faculty of Medicine, we have two barriers for that kind of research. One is our Clinical Research Ethics Committee, and since March, I guess, 2020, just COVID study applications exceed 100 in our ethics committee, and we have another research coordination committee, and there we have evaluated, just specialized on COVID. We have almost 150 studies. They don't overlap because there might be studies which don't go through our ethics committee, but other ethics committees. So we need to rely on scientific method, which is as listed. I'm not going to read them out. And we have to stick on ethics in science, starting from not doing harm, honesty and objectivity, equality, and so on, and animal rights, and actually environment. And our standard, gold standard, is evidence-based medicine. There are very hard to pronounce words. Conscience, how was it? Conscientious, explicit and judicious use of current best evidence in making decisions about the care of individual patients. And this is the grace part of my presentation. Yeah, this is our goal, as Betül has stated, and actually Ahmet prepared the basis of this type of mentality. And Betül mentioned already infodemics, but we are facing infodemic. There is a rush for finding cures and finding treatments and publishing and getting high citations. So I like this. I'm going to read this out. Actually, who has defined, again, the infodemic? And Sylvia Bryant said, we know that every outbreak will be accompanied by a kind of tsunami of information, like Ahmet stated. But also within this information, you always have misinformation, rumors, etc. We know that even in the Middle Ages, there was this phenomenon without social media, and we have social media, of course, it has been followed by thousands. So this is very interesting. I would like to draw an analogy between a pandemic and infodemic. Actually, the name reminds us to that. Virus travels through transportation networks, as you see here, and information travels through online social networks, but they have many analogies as depicted in here. And a paradigm for spreading phenomena in general are behavior, emotions, pathogens, and information. So having said that, I would like to draw very quickly an analogy between a biological information toxicity, allow me to say, and social information toxicity, where we start here with the virus genetic material, which is basically information. A virus is nothing but genetic information and its envelope. It infects, so it transfers its information to the host cell, and the host cell replicates it, and the virus can stay kind of alive. If you turn this information to a healthy knowledge, you give proper immune response, you eliminate the virus. If you have an improper response, so misinformation or disknowledge, then the infection spreads between the cells, and we have hyperinflammation, so-called cytokine storm, and it damages the body, causes kind of an intoxication. And if it is spread between individuals, we have a pandemic. And in the infodemic, you see the parallelity, the information, if it's recepted, either you properly handle it properly and then eliminate or create knowledge which you can utilize, or you create mis or disinformation, which is infodemic and which is harmful, actually more harmful than the infection itself. And this is what I call a toxic information or toxic knowledge on biological and social levels. And you can read the summary here. And we are flooded by the torrent of the information. These issues have been addressed by Betül already, so I'm going to go through quickly. People have motives, of course, in creating over-information and overflow of data, etc., because 90% of new entrants into clinical trials never make it to approval. So, and the scientific understanding of COVID-19 keeps changing all the time. So people try to have as many shots on goal as possible. You try to publish, they try to publish, we try to publish everything. This is in our nature, kind of. And journals are flooded by submissions, and the media pushes this as well. They don't publish any research other than COVID-19, and wrongly, of course, and too many scientists are working on the same subject. and making so much noise, as Betül said more technically, separating valuable signals from that noise becomes very difficult. And as she said, we are living in COVIDization, and coordination. To that, I want to come back later in a couple of minutes. Coordination is important, but we don't have time for coordination, and the resources are, as always, scarce, and they are scattered, and many small-scale trials that aren't really designed to answer the questions are done, and drugs that look promising in small trials prove ineffective in bigger studies. Collaboration is needed. On the other hand, the use of, say, snake oil treatments and supplements, which might be useful, like vitamins, but they don't have proof, they don't have evidence. The sales of that kind of treatments, that kind of remedies have boosted. This is the other part. So in what shall we trust? We trust in evidence-based medicine without forgetting it is not restricted to randomized clinical trials and meta-analysis. It involves tracking down the best external evidence with which to answer, clinical questions. I'd like to draw your attention to 4 publications, and I'm coming to the end. There is this Lancet, there is this article about Surgisphere. Ahmet talked about the results, and I think Thomas is going to talk. So they had 2 large publications, one against hydroxychloroquine and one pro, what was that? Ivermectin. So I'm coming back to that. But their data, this is doing research just relying on data, and we have to be really very, very critical in using data and on research on data, and I hope Rita is going to touch upon that point. This is the Nature publication, which emphasizes collaboration and says, takes remdesivir as an example. And this is an article about face masks. As Ahmet stated, it's been claimed, and actually Betül stated, we don't have evidence for using masks. This is a very nice article and says you should see this as a sign of altruism and solidarity, actually, before everything and evidence. I will summarize that. And there is this nice Leipzig German experiment test. They put people into a concert and make 3 groups, one strict distancing rules, one moderate, and one no rules, which has been criticized from ethics standpoint. So this is the summary of the Surgisphere thing. We have to really remember this experience. And this is remdesivir, one of the most promising drugs maybe, or claimed to be most promising. But even there, we don't have enough evidence because of small studies, non-collaborating studies. And with masks, we have lack of concrete statistical data, but it's common sense. And actually, evidence snobbery has to have a limit as well. This, I think, with the masks, we have to keep that in mind. And there's this German. This is some kind of evidence creating, but ethically a strange experiment. So we have ethics in our hands, and with ethics in epidemics, we have some issues on the provision and standard of healthcare delivery, privacy and confidentiality, informed consent, of course. This is what we like as ethics committee members, community engagement, benefit sharing, and resource allocation, which is important. And there are published rules and guidelines by the and ethical standards that research must meet. We have scientific validity, collaborative partnership, fair and voluntary participation on the and this is social value, which are related to these titles, reasonable risk-benefit ratio and independent review, and equal moral respect for participants and affected communities. And these are the points to be asked. I'm not going to repeat for the sake of time. You can read the main points, but these are very important, as you see, to solve the questions which rose until now in this webinar. If the research impedes with the emergency response efforts, this is important. Collaboration, again, community engagement, independent ethics review. Can research methodologies be adapted in emergencies? Of the recruitment of the participants and informed consent in emergencies, and data sharing, and how should research benefits be shared in emergencies. The last, one of the last points is actually, this is a very nice publication of the UNESCO. I would recommend you to read this. You see very fine examples with actually comic characters on deciphering the COVID-19 disinformation. I just want to point out, this is something deliberate. This is not something automatic thing, or it's not on related on nature of things. There are some interest in that, and these interest groups deliberately push the parts, the columns of this information. You can read here, you can have an impression, and you can read this excellent publication. And because this is a kind of an organized crime, you have to combat this pandemic, this infodemic with organized efforts, and these are depicted here. And lastly, this is my last slide. There is too much information, a flood of publications. One human brain cannot analyze them, and one researcher, one scientist, one person cannot go through, even specialized in her or his field, cannot read all the papers on COVID and cannot judge if the methods are valid, etc. And for that, I hesitate to talk in favor of artificial intelligence, but here there are some solutions. This is one of the examples. Semantic artificial intelligence, say, not program, but set, helps researchers in finding out valid and related information to the field in question. And these are our tools to overcome this flood. As Betül, I would like to conclude. I don't have a definite answer, but I think with this kind of efforts, we will come close to an answer. And with that, I finish, and thank you. Now we come to our discussion session. Until now, I guess we did not. Do we have any questions until now? Okay. So in a way, it's disappointing, but relieving for the sake of time. But the speakers can ask questions and to the other speakers and say, we have 10 minutes for that. Would you like to ask questions to the other speakers? The speakers who have spoken until now and who are going to be speaking can ask questions.
Can I ask a question, Thomas Niemstra here?
Of course.
A very thought-provoking series of talks. Thank you so much to colleagues for that. I'd like to put out a question that I don't know the answer to, and that really I was thinking about during the earlier talks. There is an obvious tension in how we respond to something like COVID-19 between the sort of policy-driven treatment strategies that we introduce, and the importance of generating randomized trial evidence. So my question really is, thinking out loud, how do we balance this tension between wanting to rapidly introduce best practice and accepting that best practice may be light on evidence, and getting as many patients as possible into trials so that we can generate that evidence?
Ahmet, would you like to answer, because you are involved in many parts of these actions? I cannot list here even.
Well, as you mentioned, there is no clear answer for this question, but I think we have to find way or alternative ways to run both clinical trials with adaptive methods, both to provide our patients reliable treatment options and also to collect more information, especially for the placebo arm or standard of care arm. You know, having a basket or umbrella type of trials and running just one placebo arm and many other treatment options as the other arms would be one of the choices. But even in this setting, it's becoming clear that there is big patient heterogeneity, and there are also channeling biases depending on the inclusion of different clinical centers, which have differences in terms of their attitude to the disease or even their inpatients. So I think we have to combine both some sort of randomization and also data analysis for comparing their, let's say, subsets or clinical differences. So using both the randomized clinical trial type of analysis and also some sort of analysis which is being frequently used in retrospective data analysis, such as propensity scores, etc. So we need to combine all of them. Since we really don't know the disease characteristics, especially variability in the disease course, we have to develop many alternative methods and to explore all these findings. I think the randomized clinical trial data showed us some hints. For example, the anti-cytokine treatment data is really quite surprising, but it's been run in a setting which is testing the efficacy of these drugs in just, let's say, bad prognosis patients without targeting their main aim, cytokine storm, but only patients who are requiring respiratory support or COVID-19 pneumonia, which is not, you know, an overall treatment aim for this type of set. So subgroup analysis or the definition of a group of patients which might benefit from certain treatments would really be helpful. So I think we have to exploit all type of information we collected from retrospective data or clinical data, and then to reanalyze them for finding the solution.
Other questions, comments? Okay, then I did not prepare any questions. I'm very content with the talks. So why don't spare 5 minutes? Maybe we will need them later. Then I move on to the ICN part of our webinar, and I see that Ming is there, and for Ming, it's late in the evening. So at the beginning, I thank him for waiting for us for the late hour. And I invite Ming Wan, who is the Director of Clinical Research Department, Shanghai Clinical Research Center, and who is, of course, a member of the steering board of the ICN, to talk about his topic, fighting COVID-19 in Chinese way. Yeah. Welcome again in Istanbul, in a way.
Hello. So let's start or have a rest. Okay, hello everyone, dear Professor Yaz and dear ICN Chairman Thomas and all experts, good afternoon. I'm Ming-Wan from Shanghai Clinical Research Center. Firstly, I feel so honored that in this period, I'm invited to participate in this webinar symposium about the grace under pressure. So I got the opportunity to share some strategy, knowledge, and some experience changes in the COVID-19 in China. So my topic is fighting COVID-19 in Chinese way. So we all know COVID-19 has emerged over several months since its outbreak in Wuhan city in China. The pandemic has severely affected the economy, the human life in our world. Since August, over 84,000 people in China has contracted the coronavirus. Globally, the virus has affected over 20 million people so far and caused more than 70,000 deaths. To combat the virus, the Chinese government announced a series of measures, including the cancellation of all Chinese New Year celebrations and a strict nationwide lockdown. On February, the 25,000 square meter Huoshenshan Hospital was built swiftly with a capacity of 1,000 beds to expand the hospital capacity in the epicenter. On March, WHO officially declared the novel coronavirus a pandemic. A week later, the Chinese government reported no new domestically transmissions for the first time. On March 31, our National Health Commission announced that it would begin reporting the infection number of symptom-free individuals who tested positive for coronavirus after no new deaths reported for the first time. China lifted 10-week lockdown on Wuhan on April 8th, 2020. Daily life was returning slow back to normal in the country. Now we think we have succeeded in containing the spread of the virus in this period. Next slide. Why has China achieved temporary victory while some countries haven't? We think it's not because China has a strong public health system. We've been learning from the Western and other countries, but this time we won the battle because the whole country was involved in the fight against the pandemic. My opinion is that China's advantage in its against the virus include a coordinated mechanism under which various government departments work together and the scientists could have a direct dialogue with our state and national leaders. And the biggest difference between China and some other countries in containing the pandemic is in community management. China's capability to make sure every individual in affected communities were tested. Next slide. Also, another factor in China's success was the speed with which close contacts of COVID-19 patients have been separated and isolated. Mass gatherings were strictly education centers were closed and the social distancing was the new normal of the city. The concerned authorities made sure that there were minimum people on the road. Many new hospitals were built in few days as the national emergency loomed. But in this prevention strategy, China also faced some challenging this pandemic. The COVID-19 crisis fundamentally changing the health system and our society in China. Next slide. First is about the budget and the money impact. Before the COVID-19, some financial institutions estimated the spending would grow to 6.6% of GDP in 2020, and that the economy would expand by 5%. Given the impact of COVID-19 on the global economy, China's GDP growth is now more likely to be in the range of 1% to 2%. To maintain of 2019% of GDP in health spending would lead to a decline of about 400 billion in spending this year. Next slide. On a more positive note, there are some areas that may see increased budgets. Following the SARS crisis in 2003 in China, the government announced significant upgrades to CDC infrastructure and information systems. Data from SARS crisis show Beijing outpatient flows and the inpatient number rose 22% and 28%. Respectively, in the year following the outbreak, healthcare spending increased and continued to rise in the next few years. A drop in hospital patient flows and the experience of previous crises suggest industry revenues will have fallen sharply in recent months. However, previous episodes were followed by speedy rebounds. Given the importance of digital solutions during COVID-19 quarantine period, it would make sense to see more support for 5G nets and artificial intelligence. This would also reflect the pattern of increased technology investment after the crisis. Next slide. Second is about the health industry. As COVID-19 took hold, hospitals shifted resources and capacity to treat infected patients. You can see the latest data shows about 40% decline in hospital visits across the country, except Hubei province, Wuhan. In February, Class 3 hospital like the hospital affiliated Fudan, Jiaotong, Beijing University took the biggest hit with a more than 50% decline in patient volume. Outpatient numbers fell by 68% across the abroad in February, and the sales of prescription drugs declined by 27%. Both have now started to recover, but many hospitals are still operation below capacity. After the crisis, demand of healthcare will inevitably normalize, but patient flows may continue to shift toward mid and lower tier hospitals, online platform, internet hospitals, and online pharmacies. Next slide. But luckily, drug development continued at the height of the outbreak. There was no sign of delays in approval in January and February, and the regulatory pathway remained open. The NMPA granted 164 approvals in the first quarter, compared with 140 in the same period last year. The trend illustrates the NMPA's determination to continue to drive innovation. Next slide. Another part is the policy impact. Health care policy continued to evolve during the outbreak. In January, the National Healthcare Security Administration published new rules relating to how retail pharmacies should handle basic medical insurance, and also the NMPA published a new serious guideline and the rules relating to how to conduct the clinical trials and how to manage the clinical data in the pandemic. Another news, on April 7, Shanghai published the guidelines on the creation of a new public health emergency management system by 2025 to cope with major epidemics and public health emergencies. Shanghai aims to become one of the world's safest cities by 2025. The program's primary focus will be on prevention and the city will leverage big data, artificial intelligence, cloud computing, and blockchain to bolster epidemic prevention and control. More specifically, Shanghai will establish a city-level public health emergency command information system and a smart decision-making platform. These will inform decision makers and help them coordinate medical resources and communicate with some stakeholders, organize department, and predict trends. Next slides. China National Health Commission released a notification in relation to online diagnosis and treatment of COVID-19 that aim to establish province-level online medical services platform and COVID-19 prevention and control management, integrate and publish register internet hospitals and internet diagnosis and treatment platforms, pilot reimbursement programs for internet hospital in Wuhan and Shanghai. So digital acceleration is also informing longer-term planning. And next slide. So as the crisis abates, child activity is picking up, and some companies are refocusing on mitigation strategy and risk management. Technology will be a critical tool in enabling virtual trials, digital monitoring, and logistics. And at the same time, some pharmaceutical company could develop a strategy approach to site selection, probably planning for an overall increase in the number of sites where drugs can be self-administered. And company may consider hiring certified cold chain logistics company to deliver directly to patient homes. Next slides. To help foster a more robust healthcare ecosystem, the government is likely to continue to develop and enhance healthcare policy. Possible policy include new standards for retail distribution and legislation to encourage online diagnosis and care. There may be moves to encourage and boost clinical trial sites and data management. To support innovation, the NMPA is likely to continue to explore new pathways for approvals. Finally, authorities are likely to establish a strategy reserve for critical medical supplies around the country. Next slide. And COVID-19 has accelerated the transformation of traditional clinical trials. The figure illustrates the corresponding development stage from traditional clinical trials to virtual clinical trials. Remote trials represents a relatively new clinical trials approach that follows the entire process of clinical. These trials collect efficacy and safety data from trial subjects remotely and take full advantage of information technology like electronic system, the APP, etc., and the network platforms for each stage of clinical trials, including subject recruitment, informed consent, patient communication, patient consultation, as well as clinical endpoint measurement and adverse event collection. Decentralized clinical trials rationalize telemedicine and local medical resource allocation, and they can accelerate the process of clinical trial. But there will also be some follow-up difficulties. And currently, the virtual clinical trials are still in the development stage, but they are not suitable for those require large instruments, CT, MRI, or complex testing. Maybe I believe in future they could be used in suitable for phase 4 or some observation trials. Next slides. Also there are also several challenges and a new opportunity for ethics committee following the COVID-19. During the early stage of the pandemic, no one knew the most effective cure for COVID-19, resulting in scientists and companies submitting various protocols, including the use Chinese medicine, Chinese traditional medicine, different therapy, different equipment, and etc. The main challenge becomes how to correctly identify if the trial meets the requirements. So it's vital to include more experts from wider areas. So in our center ethics committee, we recruit many experts, include the scientists, the investigators, especially in the infectious field. So further ethics reviews will rely largely on technology, be more intelligent, remote, and efficient, and cover a wider range of areas. So lastly, I express some words overcoming. Next slide. Overcoming difficulties have helped us to grow stronger. Confronted by this virus, the people have joined as one and united their efforts. In this battle, China will always stand together with other countries, and solidarity means strength.
Yeah.
I believe the world will win this battle. So last in this period, thank you, thank ICN and thank Istanbul University for establishing the good exchange platform and give me the opportunity to share. Thanks listening. Thank you all.
Thank you very much, Ming. Actually, it was our pleasure to have you and to hear about all this original information. So we move on with the chairperson of the ICN, Thomas Hiemstra. I have introduced him already, so I'm not going to repeat all his title. So Thomas, please, the floor is yours.
Thank you very much, Professor Irizin. Thanks, Ming, for inspiring talk also. So it falls to me to take on a topic which is arguably one of the most infamous and troubled stories from this pandemic. Some of this has been touched on already in some of the earlier talks. I should declare a conflict. I lead several COVID-19 research projects, one of which is a trial which includes hydroxychloroquine. So some of what I'm about to tell you is the inside track from the UK. So a brief background: hydroxychloroquine has been around for decades. It's licensed for the treatment of inflammatory conditions such as systemic lupus erythematosus, rheumatoid arthritis, and of course as a prophylactic agent for malaria. And hundreds of millions of doses of hydroxychloroquine have been dispensed worldwide over the last few decades. And prior to the COVID-19 pandemic, it had a good safety profile. There is a long literature of hydroxychloroquine as an antiviral agent, both in HIV and in other viruses. And these data on this slide go back to 2005 and 2009, respectively, to the SARS outbreak, where there was evidence of in an in vitro model of a dose-dependent inhibition of SARS. And the panel on the right shows a rodent study, a murine model of SARS pneumonia, in which, again, hydroxychloroquine improved survival of these animals. So encouraging historical data. Seem to be missing a slide, apologies. So more recently, data emerged in January and February that suggested that hydroxychloroquine might have a role to play in SARS-CoV-2. There were reports from the early experience in China suggesting that hydroxychloroquine improved patient outcomes, and some in vitro data shown on this slide replicating the 2005 data for SARS in a vero cell model showing that SARS-CoV-2 was inhibited. And these data were fairly rapidly replicated convincingly. The panel on the right shows that for, again, a Vero cell model, for cells treated with hydroxychloroquine after being infected, this was effective, but importantly also for pre-treating cells with hydroxychloroquine, that this was effective against SARS-CoV-2, suggesting that perhaps also as a prophylactic agent, hydroxychloroquine has promise. And based on these data, some large trials incorporated hydroxychloroquine into their protocols, most famously perhaps the WHO Solidarity trial and the UK Recovery trial. And after this, the paper that you'd already heard about in the first talk today by Didier Raoult's group from France, in a small series reported an improvement in viral clearance in patients treated with hydroxychloroquine. It was a small study. It was not randomized, but nevertheless, these data were encouraging, and coming from this particular source, Didier Raoult being one of the most cited scientists in the world, this was taken very seriously and very rapidly entered the mainstream media at this point. And the media, as you'll see, played a strong role in this whole story. In the UK, this was widely reported. It was mooted as a breakthrough for treatment of coronavirus. There were surveys of thousands of doctors published reporting in the national media in the UK that more than 2,000 clinicians thought that hydroxychloroquine was the most promising treatment. And more worryingly, perhaps, stories began to emerge that suggested that perhaps this new interest in hydroxychloroquine could threaten supply of hydroxychloroquine to those that need it for inflammatory conditions, and reports started emerging of countries and organizations stockpiling the drug under this new interest. On social media and elsewhere, some interesting pieces of news emerged. So at the top middle there, Elon Musk tweeted that maybe hydroxychloroquine should be considered. There was a report from a clinician in New York reporting 100% success rate in 350 patients treated with hydroxychloroquine. President Trump called hydroxychloroquine the biggest game changer. And the US FDA then announced an emergency authorization for the use of hydroxychloroquine in clinical care. And then, as I alluded to earlier, there were concerns emerging over people being protective over their existing supplies of hydroxychloroquine. And that includes the situation in the UK, where it's on the list of protected medicines for a variety of reasons. President Trump then famously stated that he was taking hydroxychloroquine, and on this wave of enthusiasm, a whole series of trials started incorporating hydroxychloroquine in platform protocols or doing exclusively hydroxychloroquine trials. And this is not an exhaustive list, but lists some of the more prominent ones: the Discovery trial run out of INSERM, and then Recovery and Solidarity we've already mentioned. But some of these trials, the principal trial in primary care, 6,000 participants, the COP-COV trial, 40,000 healthcare workers, placebo-controlled randomized to hydroxychloroquine. So a huge amount of interest in using hydroxychloroquine in a variety of settings. This graph on the left shows a bar chart. The y-axis shows the sample size for registered trials incorporating hydroxychloroquine in COVID-19. Almost 250 trials, which gives you an idea of scale. The y-axis I've truncated at 10,000. The COP-COV trial is the very right-hand bar, which of course was up to 40,000. But one of the striking things looking at this is the sheer volume of trials using hydroxychloroquine as an intervention. It's also striking that more than 80% of these trials have a sample size, a total sample size of fewer than 1,000 patients, and most of them fewer than 500 patients. And of course, it isn't realistic for most of those trials to expect that they would be in a position to detect a significant difference or a clinical meaningful difference. And so this represents a huge global effort, but also represents a large degree of competition between investigators, between trials, and inefficiency in the research response to SARS-CoV-2. This is the third time by my count that you'll see this little triangle in today's seminar. The point here just really is that the pinnacle of clinical evidence is the randomized trial and systematic reviews of those trials. This is the evidence that we need, but these experiments take a long time to establish, to conduct, and to conclude, and then to report. And when the world is impatient for answers, the less robust forms of evidence proliferate, and that was certainly the case in an unprecedented manner for SARS-CoV-2, with a huge number of publications that have already been alluded to. And the hydroxychloroquine story was not immune from this. Doubt surfaced now infamously on the 22nd of May when this paper was published to great fanfare by The Lancet with media releases and such. This is from the Surgisphere dataset, a company that's US-based and claims to have electronic healthcare record data on millions of patients from across 5 continents, and reported almost 100,000 cases treated with hydroxychloroquine or hydroxychloroquine and azithromycin or other macrolides, and reported 2 key features, both of which were very worrying. The first, that in-hospital mortality was increased by hydroxychloroquine with an odds ratio of 1.35, and second, that fatal and non-fatal ventricular arrhythmias were increased with an odds ratio of 2.36. These were very worrying statistics, of course, and very rapidly were disseminated in the national and international media in the US. There were reports such as this. Al Jazeera picked up the story, increased risk of death. It was in the UK on all the news outlets, including the BBC. The Washington Post picked up the story, and there were conflicts and accusations flying about, and people claiming that this was the case or wasn't the case, and it was all very messy and fraught. More concerningly, this particular publication, the Mirror paper, led within 24 hours to the halting of a number of trials. This was led, unfortunately, by the UK healthcare regulator, the MHRA. They put out this press release on the 16th of June, 2 weeks after they had communicated directly to the steering committees of a number of trials, which included recovery, COB-COV principle, and a number of other studies, requesting that the steering committees halt recruitment with immediate effect. And this followed a weekend of frantic communication between trial steering committees, meetings with the MHRA and others, the end result of which was that the recovery trial was allowed to continue recruiting. At the time, it had enrolled 1,300 patients to the hydroxychloroquine arm, so it had accumulated a significant amount of data. The DMC carried out an urgent review which showed no adverse safety signal, and so recovery was allowed to continue, but the other trials remained halted and were not permitted to restart. And the press statement that was put out included this statement down at the bottom: new participants, and no new participants will be recruited to these trials until further data which justifies continuation have been provided. So a huge amount of effort to generate evidence in a variety of settings stopped dead in their tracks by this one observational study published in a very high profile journal, as alluded to already earlier. This entered the international media, of course, and other trials followed suit. The WHO stopped recruitment hydroxychloroquine in solidarity, and the whole effort ground to a juddering halt. The US FDA then withdrew their emergency authorization for the use of hydroxychloroquine. And at this point, a number of collaborators, trial steering committee members, and other investigators came together to consider this paper in The Lancet and some very real concerns over the integrity of this report. There were a number of implausibilities in the paper, to give you, I'm not going to go through all of them, but to give you one example, baseline characteristics, the prevalence of smoking was about 9% in all continents, and we know from existing epidemiological data that that was highly implausible. And there were a number of other inconsistencies which made many people suspect that these data were not robust and could potentially be fraudulent. An open letter was sent to the Lancet. This letter was not published, but the Lancet did put out a statement of concern about this paper, which was published a week after the original publication. And 12 days after the original publication, the publication was retracted by one of the 4 authors on the paper. That was reported in the media, but to a much lesser extent than the original report, and to a large extent the damage had been done, and many of these trials never quite recovered from the adverse publicity that was gained. Patients were distrustful about this drug that led to increase in deaths, and it became very difficult even for the recovery trial to continue recruiting to hydroxychloroquine. So a very damaging impact from this particular publication. Thankfully, there were some reports, some studies that were allowed to continue, recovery being the arguably the highest profile one, and the first to report on hydroxychloroquine, and reported in mid-June that there was no significant benefit of hydroxychloroquine on the primary endpoint of 28-day mortality. There was also no significant increase in adverse events with hydroxychloroquine, but certainly no evidence of benefit, and the direction of the effect was in favor of usual care rather than hydroxychloroquine. In short succession, this paper was published, that was mentioned again in the first talk by Bulwer and colleagues, which was a post-exposure prophylaxis trial, not particularly well conducted, about 800 participants. The bottom line is that this trial was negative. It showed no benefit of hydroxychloroquine prophylaxis post-exposure, although I'll return to this shortly. But these reports of no benefit with hydroxychloroquine led to the discontinuation of a number of other studies. The NIH halted their hydroxychloroquine trial. WHO discontinued at this point the hydroxychloroquine arm of Solidarity. And this led to some accusations and a lot of speculation on social media and elsewhere, people claiming at this point that the answer was always clear from the beginning. It was silly to try hydroxychloroquine, it was never going to work, and really led to a lot of unsavory dialogue. There was this high-profile publication in the New York Times magazine, which was very critical. But we must remember that some of these early reports emerged at a stage when the fog of war, as they say, was blinding, and where we had absolutely no inclination of what the right thing was to do. And there is an argument to say that some data is better than no data. So we should be very wary of being too critical. And one of the lessons, unfortunately, that I and others have learned is that we are often very unkind to each other when it comes to conducting research. So is the story over for hydroxychloroquine? I am not going to discuss this in any length, except to point to this subgroup analysis from the Bulwer paper. So this is the post-exposure prophylaxis trial. And what you see in this forest plot are the point estimates by the day post-exposure that hydroxychloroquine was commenced. So if hydroxychloroquine was commenced one day after the exposure event, then this is the point estimate, and then 4 days after the post-exposure event, this is the point estimate. And more than 50% of the trial population were treated with hydroxychloroquine only after 3 days after the primary exposure event. And it is very striking that the earlier the start, the greater the point estimate in the direction of benefit. Given the power of this particular experiment, one does wonder whether perhaps there is a signal here, but the experiment was just not able to detect that. And so I share the view of one of our earlier speakers that this story is not over, and we look forward to other trials that have been allowed to continue in other parts of the world reporting on hydroxychloroquine. So finally, I will leave you with 4 conclusions that I take from this story. The first is that we have to be ready to move very quickly and start testing interventions in randomized trials if we are ever in this situation again. And we can learn from initiatives such as Solidarity and Recovery that if we are poised and ready, it is possible to generate high quality evidence at scale very rapidly. But we have to be ready to move quickly and not have obstacles in the way and unnecessarily burdensome and complex protocols. The second lesson surely is that we must collaborate better than we have done during this pandemic. We have collaborated to some extent, but if you look at the sheer number of trials of hydroxychloroquine, if we had pooled some of those studies, we would have had the answer in a small number of weeks. And so we should learn from this that we must collaborate better and build systems and networks that allow us to do that. Third, there is so much hype in such a circumstance, and we have to focus on the science, on designing robust experiments, and not participate in emotive discussions that happen in the media or on social networks. These are not helpful and do not advance our understanding of the pandemic. And finally, another clear example that observational data is no substitute for robust evidence from randomized clinical trials. So with that, I thank you again for the invitation, and I'm happy to take questions. Thank you all.
Thank you very much, Thomas or Dr. Himstra. We are being official. Thank you very much. There are questions, but I will leave the questions to the discussion part. So I would like to move on with the next speaker. And the next speaker is actually our special friend, Professor Gabriele Senti. She's the head of clinical research in Zurich University Hospital, but she is the actually founding chairperson of ICN. And I am, with this meeting, I realize again that we should be very thankful to her because she made this very nice society possible, and we have such valuable friends and scientific collaboration. This is her doing, actually, at least at the beginning. That's why I would like to thank her again, and I leave her with her presentation, the name she can pronounce. Okay, please, Gabriela, welcome. Hoş geldin.
Thank you. Thank you very much, Joyce, operation team, dear friends, dear colleagues. I'm very happy to talk. So may I ask for my first slide, because we have Zoom is forbidden in our hospital. So yeah, Dr. Club is helping. So especially I would like to thank Anja Eskat. You know her from the operation team. It was an intense time we had over the last 3 weeks, because the times are changing in the research, vaccine development so quickly. So she was a great help for this talk. Next slide, please. I would like to disclose my conflict of interest, because by training, I am a clinical immunologist, and I am involved in a COVID vaccine project. The company is called Cyber. So hopefully you will hear a lot about us, but this is my conflict of interest, of which I'm very proud of. Next slide, please. In Switzerland, we had a tough situation because we were Alsace in France and Bergamo in Italy, where they had the first outbreaks in Europe. So we were critical and still now with the second wave, it's rolling on, and I think we are now number 6 in Europe with the positive numbers. Next slide, please. Like in other places in Europe, we have especially the young people infected, but of course we are afraid that they will infect their parents, and then we will have full hospitals again. So this is just a word. I was happy to hear from Ming the situation in China. You can be sure, Ming, that in Switzerland it was pretty different with the lockdown. So lots of democratic discussions, and at the end of the day, quite a late lockdown, unfortunately. Yeah, let's talk about vaccination. You have heard a lot from the previous speakers about SARS-CoV-2, and to my opinion, and to others, of course, we have only one chance to treat or to act in this pandemic, and this actually is the vaccination. Herd immunity is no option. I will come to this later in the next slide, but up to now, when we consider all the difficulties in serologic testing, we think that we are not over around 15% of infection rate. So there is a lot of people still susceptible for the virus. Next slide, please. Many or some epidemiologists now raise the question whether we just should wait and wait for the herd immunity. I think you have followed the discussions in Sweden. There is also one person in Switzerland who has this opinion, but there are clear examples that this is no option. I am sure that I'm repeating because you read the newspapers as I do every day, 24 hours, and there's so many news, but this sad story of the prison of St. Quentin showed clearly that herd immunity is no option. As you see, out of the 3,000 prisoners, 2,200 were tested positive and 25 people died. So this is a much higher death rate than we have now. So no herd immunity, only vaccination. Next slide, please. Thinking about accelerating the vaccine is the issue of today's talk. So I tried together with Anja to really have this discussion about the pressure and the ethics and the grace. So we are all aware that if the development is fast, we can save a lot of lives. You see here an estimate, like 1 month saves more than 100,000 lives. So there is definitely a lot of impact, a lot of pressure of accelerating vaccine development. But we always have to be aware that this is not an individual cancer treatment. This is a preventive vaccination of healthy populations, of healthy people. So the vaccine really has to be very safe. Next slide, please. Up to now, drug development as its classical way for a vaccine, we have heard it in one of the previous talks, takes up to 15 years. Like measles was a little bit faster because there was some work done before, but in SARS we have the problem because MERS had some initiatives to create vaccines, but then it disappeared. So there was no pressure on industry and on research to further develop. So we have a large lack of development in the COVID vaccination trial programs. There are models of conditional approval. Let's say you do a phase 2 and then you have this conditional approval and you do a large phase 3, which actually is already kind of a population vaccination. There are some models, but the companies, what we are seeing now, and also we in our company, we try to do that, is that you go for highest risk. So in fact, you start GMP production when you don't even know whether it works or not, because you have to have the material already for the phase 1 trial. So this is at highest risk drug development. Next slide, please. But if there is so much pressure and people read this in the newspaper, this is very interesting because this raises fear and this raises a lot of concerns in the intelligent population that they think, what are they doing? There is so much pressure. So do I really want to get vaccinated with some stuff which didn't was developed properly? So what you see here is a clear decrease of the willingness to be vaccinated. I'm not talking about the countries where there is a compulsory vaccination program. We don't have this in Switzerland. So there is a counter movement of people when the pressure from industry is high, that they say, oh, no, I better wait and I see how the results are going to be. So this is there is a clear link between the two aspects. Next slide, please. And there is another problem, or not problem, there's another fact. Of course, also you have heard and you have read that there's a big hype about the companies. And for the first time ever, the vaccine development or the drug development became kind of a nationalism political issue. So all countries which have their own vaccination program started to invest a lot about in these companies. Like Moderna, they got over $1 billion to be invested, but in fact Moderna a few years ago was a nobody company, a startup company, and there is no product of this company on the market. But the investments and the hypes and the national support was so big that now this is one of the first companies. But there's this very special mixture between science and development. I mean, the development and also nationalism. Everybody wants to buy and invest the money for their own people. So there is also then the counter movement of the global approach. Next slide, please. This is very special. Another slide about the politics. Like in Twitter, there was a message that Donald Trump attacked FDA because of course he wants to the vaccines being approved before his elections, but also there is a national competition between the countries. Last week we read this article about China and Russia, who was first. China was first and Russia was first, and China declared that no, that was not true what they said. They were even 3 weeks before. So this is very, very interesting. Also, there was a TV interview with an Indian company that they started to go into vaccination without approval, but we tried to look for it, and then for juristic reasons, it was taken down by the new newspapers. So lots of challenges. But in fact, this vaccination campaign is so big that this is really very, very important that we get the national support, because there is a demand of more than 10 billion vaccines shots, because normally you have to be vaccinated twice. So the biggest ever was polio, and that was only 450 million. So you see about the logistics. Maybe at the end of the day we have vaccines, but we do not have the freezers to transport them, or the planes to. I have read that you can only transport 1 million doses in one plane, so it needs about 500 planes flying all over the world. So there will be huge next slide, please. There is a counter movement of the WHO. Maybe you have heard about the Solidarity vaccine trial. The idea behind this is that this trial will take place in different countries and with different products in the same time, because they say, and this is true, this is the only way you can compare the vaccines. This is a very nice initiative, very helpful. Next slide, please. there is a summary on New York Times, which I recommend, and Anya was so kind to put the latest numbers from yesterday in. This is like a creamy, and you can read it every day, and you see the latest developments. So up to now, over 130 are into preclinical stage, 21 phase 1, 13 phase 2, 8 phase 3, and 2 are already approved. One is in Russia and one is in China. There is an approval for the military people. Please. You see here a short summary about the different products. And what I want to point out is, in fact, that one of the biggest companies, some of the biggest companies, also in phase 3, they are working with platforms which have never been approved to do prophylactic vaccines, such as messenger RNA or adenoviruses, Japanese adenoviruses, or DNA products. And so there is a lot of risk for those people, for those companies, still that this is not going to work. These technologies originally, as I said, have been worked in immunology for the cancer treatment, for the individual cancer treatment. So there are also others like nanoparticles, viral vectors, and so on. Next slide, please. There are some limitations which we face now and which will be very important. For example, it is important which domain is chosen of the spike. There is this S1 spike, and there is the receptor binding domain, or for example, it's a big challenge to establish the tests. Maybe you have read the Moderna paper on their phase 1 results. So you see that neutralization tests are very, very difficult to perform. And also the test has to be established, and to compare the results is difficult. Also, one of the previous speakers mentioned this, because you do not know what is normal. You do not know what is the medium of a normal titer of a reconvalescent person. So how high do the titers have to be? What level of neutralization do you need to be actually protected against the corona infection? Yeah, next slide, please. I mentioned the few companies, and I really recommend, if you're interested, to sometimes check this New York Times update. There's also a newsletter, you can read it daily, where you see which company entered which phase. And this is just from the last 2-3 weeks, and you see how much happened. And of course, the stock market reacts in a few hours, and these companies are now worth a few billions, but actually no one knows whether it works. Next slide, please. These are a few companies which launched phase 3. Moderna and BioNTech are, at least in Europe, the most well-known. They are based on a messenger RNA vaccine. Next slide, please. Then some viral vectors. The most famous is the cooperation between the University of Oxford and AstraZeneca. They're also in phase 3 and just recently got 1.2 billion US. Next slide, please. Protein-based vaccines and virus-like particles. You see here the SIBO. We use virus-like particles, which is an established platform. Maybe you know Gardasil, the HPV, the girls' vaccine against cancer, or hepatitis B is also based on this technology. Next slide, please. Another few companies. Whole virus vaccines. Next slide, please. There are some concerns about the effectiveness. FDA and EMA and also Swissmedic decided that they won't go for conditional approval, but they want big phase 3 trials. So also the previous speakers mentioned there are some open questions. Maybe you had already harmless corona infections a few years ago, and maybe you have pre-existing antibodies, and also there are some concerns. We had another symposium in Istanbul where you organized, where we were talking a lot about that maybe one of the escape mechanisms of the SARS-2 virus is that the antibody response is very bad, and low titers. This is one of the escape mechanisms to introduce only low titers. Next slide, please. So the conclusions are that there is a big gap between industry pressure, nationalistic pressure, political pressure, economic pressure to be fast and to throw something on the market, where, let's say, in the example of RNA, you don't really know what it does. Where does it replicate? What does it replicate? How long does it replicate? But there's so much pressure and the end of the day election issues that people get stressed. They say, oh, no, we first want to see the results. Also, the regulatories, they say, we might better go for a clear phase 3 trial, not for conditional approval. But there is one need, and the WHO made it, but the political forces, the warp speed forces are maybe stronger, that we need solidarity, we need cooperation, we need properly designed clinical trials, comparison between the products, between the reinfection rates. Also, there is this question of antigen-dependent enhancement. So there are lots of open questions, and maybe it is not realistic to have a vaccine in 1 year, because maybe there was a reason behind that it took us 15 years, but we will see. And of course, we will hope that we can be as fast and as safe as possible. So I thank you very much for your attention. I think this was my last slide.
Yeah, thank you, Gabriela, for this really provocative and multidisciplinary, actually, presentation. I'm sure there will be questions in our discussion part. Now we move on to Dr. Britta Lang from Albert Ludwig University Freiburg and head of clinical trials unit. I will read out her title because I made it up from what she wrote. COVID-19 pandemic in light of evidence-based study planning. I hope that you are happy with that title. And now the floor is yours, Britta.
Thank you very much. I just try to give my screen free for you. Sorry. Do you see my screen?
No, not at the moment.
Okay.
It's the green arrow, share screen.
Okay. Sorry. It's just a question of here we are.
Yeah.
So now you see it. Okay, so I have to clear up. Sorry, it's the first time. And now I will start the presentation. So sorry for being a bit late. But now we have this. Okay, do you see this green green thing in the middle of the screen, or is it only for me?
It's only for you.
Okay, that's great. So thank you very much, Jais. Thank you very much, Thomas, for inviting me to speak today in the ICN Symposium. And I was very happy with your choice, Jais, for my title, because it was exactly the thing I wanted to talk about. And I think I will go now a bit on a meta level, talking on COVID-19 research, because I'm not a doctor, a researcher, or an expert in a certain field. But I would like to talk about a bird's view a little bit. And so about COVID-19 pandemic in the light of evidence-based study planning. I also have to thank, so now I can't move my slides, that's weird. Yes, I would like to start with a citation I found quite impressive from a paper published in May 2020 by colleagues London and Kimmelman. And they wrote about the pandemic research exceptionalism. So how we do exceptions from our scientific rigor in the actual situation. And that there is a widespread perception that when it comes to the rigors of science, crisis situations demand exceptions to high standards for quality. But on the other hand, although the crisis presents major logistical and practical challenges to us as trialists, the moral mission of our research remains the same. So we should have a quite balanced stand and a firm stand in our grounding principles, what we think science and its methods are. So the grounding principles of scientific reasoning, especially in the biomedical sciences, are that we have a hypothesis on a natural phenomenon which is examined in a well-designed experiment. Beforehand, we define our information need, and then we formulate our hypothesis. The results have to be reported, transparent, and have to allow replicability. The experiments have to be repeated to verify or falsify the results. And very important, we have a self-regulation by peers and discussion of the results in context of other research. And as we are sadly aware in the moment, research is an ongoing process which can pace up very rapidly. All of us are working in different fields of clinical research. So we have a large bow in this area of COVID-19 research, from the preclinical phase to the clinical phase. And as Gabriela pointed out in her talk before me, the post-market questions and the post-market evidence when the vaccine will come one day is before us in maybe a far future. So we have all these phases where research is done. So we have a really vast field of experiments, of different designs, and of research questions which have to be addressed. So I won't remind of a very, very old paper of David Sackett, but I think it's still so valid, named Choosing the Best Research Design for Each Question, because also the often cited levels of evidence with the so-called gold standard of the randomized controlled trials depends on what question I want to answer. But at the end of the day, if it comes to effectiveness, we always have to go for the RCT, even in limited conditions, but we should strive for to realize and to answer our questions by this study design. In the last 10, 15 years, the topos of waste of research was very often featured by very prominent researchers, by Ian Chalmers, Paul Glasziou, John Ioannidis. And I just wanted to sum up the major point why nearly 80% of research are wasted, because very often it's not published because of negative results in the paper. We do not find the necessary publications because they are not in the main databases, or they are not written in the right language, which is normally in English. Maybe they are not accessible, or they have a low quality of report. Or in some countries, we have technical barriers, no computers, no internet, no license to journals and databases. So in COVID-19, we have some special aspects. We have, for example, the phenomenon that trials have been made, which have been easy to implement, but with the risk of biased effect estimates, or which have been easy to implement, but have been absolutely redundant to other huge trials being conducted somewhere else. We had a duplication of efforts, although some replication is necessary, but it should be well thought. And we had a lowering of the quality of the peer review process by publishing on preprint servers, but preprint servers, on the other hand, steer ill-broad discussion. But very often, as Thomas pointed out very nicely, we had a steered discussion by the media, and they have totally different interests in what they publish and how they publish about certain topics. And even the superstar of meta-research critics, John Ioannidis, was caught in a shitstorm this spring when he published on a preprint servers 2 papers which were highly debated, and even his very good reputation was a bit damaged by this paced-up process, which was also very strongly steered by the media. And we saw quite uncoordinated action, national and global. There were some really brilliant examples of huge trials and very well coordinated actions. But I think we should think much more in our national countries for global collaboration and global coordination of research. So this picture, which was posted on or published on Twitter by the project manager of the WHO International Clinical Trials Registry Platform by Ghassan Karam, shows the rapid speed of trials which have been registered within WHO from February to June, where we reached a number of nearly 4,000 trials in over all the fields of COVID-19 research. And here we come to a topic which is very near to me because I have been working for Cochrane so long. So when it comes to planned trials, even in a disaster situation, we need to use the evidence base to plan these studies. So we need all existing data which is existing already, maybe also from preclinical phases, everything which is there. And we need the data from all the participants already being included in trials to this topic. And of course, we have to identify all these relevant clinical trials already existing. So there have been some very thrilling initiatives, not only by Cochrane people, but by Cochrane people to find COVID-19 studies around the world, to find COVID-19 studies in Australia. Here, this special example from the Australia National Healthcare Government. And another point I will point out later is the use, for example, of standardized outcome sets for the trials which are done on COVID-19 aspects. So there's this thrilling project supported by several institutions around the world, of course, some Cochrane institutions, but also the INSERM in France. And it's a project which tries to map daily the living, ongoing research on COVID-19 and also to steadily actualize living systematic reviews where all the data on special questions is pooled. And they have a very nice website I recommend you to have a look at, where they also visualize the data they collect, and in the little field, in the search field, you can, for example, type in the drug you are looking for, and then on the left side, you will be shown all the trials which are conducted to this drug over the world. And you can also see the registration date for those trials. You can just see the study aim, and there's much more information on the site. On the screenshot was not enough place. So, and down you see the table where you can then see the trials, where they are conducted, at which institution, with which registration number, and so on. So I think this is a fantastic resource, and maybe even if it's not fully complete, probably it's the right step in the right direction to help everybody who wants to plan a new trial to get a fully picture what has already been done and what would be a senseful addition to our research. So the core outcome sets are, so for me, a very important point. This is an initiative which is called COMED. It's already existing for a while, but they have also set out now for incorporating COVID-19 trials. And they try to standardize outcome sets for the classification of outcomes, which should be reported in COVID-19 studies. So at the end, that the studies can be nicely pooled in systematic reviews, and we see an overall estimated effect size because the trials incorporated the same outcomes. So this is a very important thing, so that we have a minimum of information to support the decision makers, which is harmonized and consistent about all trials. So my recommendations for key actors in research for this background is, so firstly, we have to define what is our information need, what is the thing we really want to know. Then we map the evidence, what is already there. And then we plan our trials on this evidence base, and we use core outcome set, and we use standards for protocols. Let's cite here the spirit statement. And we coordinate research networks on a global level, and we are acting national, but with a global perspective. So then we don't waste resources, we don't waste people's time, and we can invest in the right pathways. So I would like to close, again, remembering that we are in a disaster situation, with a citation from the ethical guidelines for health-related research involving humans, which I found very, very nicely. Yes, we have now to generate knowledge very, very quickly and to overcome practical obstacles, to do our trials, to cure our patients, to prevent damages from COVID-19. But we always have carefully to balance with the need to ensure the scientific validity, which is a very important point. So what Professor Gül said in the beginning, equanimity, is a very, very good thing. Be balanced, be in your middle, and never forget your scientific grounding. Thank you very much.
Thank you very much too, Britta. And at last, we acquired some questions, but them I will mention at the discussion part. And we are coming to our last speaker, and I'm sorry for not having thanked at the beginning. We have a third sponsor, because we have Istanbul University, we have ICN, and we have ECRIN. And our last speaker is the Director General of European Clinical Research Infrastructure Network, Dr. Jacques Demotte. Herewith, I thank him and to his institution for supporting us always.
Thank you very much, Yagis. Do you see my screen now?
No, not yet.
No.
I see your books.
No, but it's not what I wanted to show you. You know, I will.
Actually, if there's a problem, the guys from Dr. Club have yours. It's working now.
Do you see the screen now? Yes.
Yeah, it's working.
So now you see my screen?
Yeah, exactly.
Perfect. Okay, thank you. Thank you very much for this invitation, and thank you for the discussion, for the quality of the previous speakers. So it will be, I will give an overview of what are the challenges and the lessons and perspective, but I think most of the item were already covered by most of the previous speakers. So the first aspect that comes to my mind when I consider the situation in clinical research in the context of the COVID crisis is the issue of funding, meaning that when the crisis started, the funding agency and the science policy makers decided to open calls for funding clinical trials on on COVID. And this was done at national level and not that much at multinational level. For instance, there was no specific call at the beginning from the Horizon 2020 program to fund clinical research multinationally. And this is one of the problems that was faced by investigator, because this was a strong incentive to run national, not multinational clinical trials. So this is something that we have to consider. The second thing is that it could have been possible to fund multinational clinical trials not only through common sources, through central budget, like for instance the European Union budget, but through the common pot. But there is no such common pot for funding clinical research, and this is something we have to keep in mind, because for the future, having some resources to be able to react and to immediately fund multinational clinical trials would have simplified the problem. Another issue is the cross-border funding, meaning it's possible for a national funding agency to decide that as far as the PI, the principal investigator, is from the country, it doesn't matter whether the patients are investigated in this country, in the neighboring country, or in Australia, or even in the moon. If the question is a question that has to be addressed and that has a positive impact on the national health system, the origin of the patient should not be a problem. For instance, there are questions that are highly relevant now for Germany, for France, or for Spain, but now the number of patients doesn't allow to answer the question in this country. So this country should have a mechanism in place to say, okay, in this case, we should allow cross-border funding and fund the clinical trials with investigation site in Mexico, in Brazil, or in Thailand. But this is currently not in the mind of the majority of the funding agency. So this is for the multinational clinical trial funding. The second aspect is the top-down versus the bottom-up decision-making process regarding the funding decision. Usually, of course, people use bottom-up mechanism, meaning that there is a call, the investigator prepare an application, and the best projects are selected. Here, the problem is that the best project were the same in all the countries, meaning all the countries had a lot of trial addressing the same question, not only hydroxychloroquine or ritonavir, lopinavir, or tocilizumab, and so on, and this resulted in fragmentation. But I think typically the best would have been to have a mixture of top-down and bottom-up decision-making, meaning that the health authority, and especially the health technology assessment, the HTA, should have a say in the decision of testing for repurposing, of testing different treatment, because they are expected to have a broad overview of the pharmacology, and also not only of the pharmacology, but also on the cost effectiveness of treatment. And I think the HTA, and this is the case in some countries, not in other countries, but in some countries, the HTA played a very prominent role in deciding how to prioritize the arms to be tested, the treatment to be tested. And the national competent authority and also the national policymaker, health policymaker, should play a role, because the national competent authority, for instance, provide the authorization, and they can identify how many trials are accepted by the national competent authority and how many trials are, let's say, redundant with other trials run in the same country or run in the other country. So I think the national competent authority should have a role here in this coordination effort, and should also play a role in deciding on the termination of trial when it's obvious that the trial will not be able to recruit enough patients and will not be able to conclude. Another point is that the the most efficient trial until now was the multi-arm adaptive platform trial, which is the case for the Solidarity, for Recovery, for Principle, for REMAP-CAP, for Discovery. All these big trials that led to some conclusion are in fact adaptive platform trial. And in fact, when you want to test multiple treatment for the same disease condition and the same patient population, the best is to share the control arm and to have a single adaptive protocol where you can open and close arm depending on the success or the failure of the trial. So this works. This reduces the timelines, of course, because you have to recruit less patients in the control group, and you have also to just have an amendment to open a new arm. This reduces also the cost because you share the cost, at least the cost of the control group. And this works also for vaccine, and this works. This was designed mostly for repurposing trial. This can be used for registration trial as far as the manufacturer, the industry is accepted to have the new drug tested in a comparative trial, meaning with the risk for them to be compared with other drugs. And this should be also a very important tool for comparative effectiveness trial. I think, for instance, in the field of vaccines, it will be important not only to have a vaccine getting marketing authorization, but for the health authority and the health policy makers, it is critical to be able to run comparative effectiveness trial on vaccine to compare the different vaccine option and to compare not only the efficacy, because what matters is not to have something with 30 or 40% of coverage, but more than 60%. So it's very important to compare and to see what is the best coverage, or to combine vaccine, or to change the doses of vaccine, but also to take into account the cost of the vaccine campaign. Regarding the characteristic of the trial, this was already mentioned, but the main characteristic of the trial are the patient population, meaning that there are the trial on outpatient, on inpatient in the ward, inpatient in the ICU, and so on. So this, of course, corresponds to different step and different severity of the disease. The intervention, it's critical, but it's not the only parameter. For the intervention may be a treatment, repurposing, or registration, and we don't have to collect the same data for repurposing, screening, repurposing, treatment, or for registration trial. It could be a matter of prevention or vaccine. The comparator is critical, and you have to keep in mind that a lot of trials that I just mentioned are open label trial, which is a source of bias, especially when the outcome is a subjective outcome. Of course, if the outcome is mortality, you can consider that the open label has less impact on the mortality, but if it is just a matter of well-being, of course, the open label can introduce a lot of bias. And the outcome, so the outcome, as mentioned, the COMET initiative provide a set of core outcome for COVID trial. I think the mortality is something that was really helpful, at least in Solidarity or in Recovery. The point is that now the epidemic is changing, and with the lower mortality, because the epidemic, at least in Europe, is now affecting younger people. So the mortality is more difficult to handle as an outcome measure, because the mortality rate is too low. So there is here a problem. And another problem, another major difference between the trial is the data collection. Some trials are hyper pragmatic, like Solidarity or Recovery, where the patient are just randomized, and then information is collected regarding the mortality at 28 days. Other trial, like for instance Discovery, is a trial collecting a lot of data on safety, data on efficacy, with measuring the viral load and so on. But of course, this has a cost, and this sort of trial is more adapted for registration purposes, while the Solidarity and Recovery model is best adapted for repurposing. And so, as I mentioned, this has a true impact on the cost. For instance, the cost of Recovery or Solidarity is in the range of a few hundred of euros per patient, while, for instance, the cost of discovery is in the range of 5,000 euros per patient. So this is not the same level of funding, of course. Cooperation versus competition was already mentioned by the previous speakers, but there is a matter of competition between countries, and this is it's not common to see the policymakers really involved in research activities, and I think this is a good lesson for the next pandemics. Please keep your politician away from research, because this result in unnecessary complexity. Between investigators and institution, and this is rather a pity, because it's not a matter of personal pride to contribute to clinical trials on COVID, and this result, of course, in competition regarding the patient recruitment. There should be incentive for cooperation. In fact, what we see is mostly negative incentive. For instance, I know that in some country, the metrics for the evaluation of research activities in the hospital or in the university, the number of trials where they act as the sponsor for the trial. So, of course, in this case, people don't want to collaborate, and they prefer to be the sponsor in a very small trial that will never get the number of patients, but they were the sponsor, rather than to collaborate with the hospital in the neighboring cities. So this is very negative. And there is need for instrument for cooperation. So we mentioned the funding, because the being able to fund multinational clinical trials, either through a central mechanism like Horizon 2020, or through an ERANET or a common pot, whatever common pot, or even through cross-border funding, is something really essential. And this is one of the main lessons from this crisis. Currently, we are also developing a tool which is called the trial marketplace, where the main characteristic of the trial will be put into a mailbox by the investigator, describing the patient population, the investigation, the comparison, the comparator, and the outcomes. And then if there is a trial matching at least partly for the same intervention, for instance, there will be a signal in order to push the investigator to work together, instead of working in a silo in their own hospital or in their own country. Support to multinational clinical trials, of course, this is something very important, and it is a basic job of ECRIN. It is really our mission to support the management of multinational clinical trials, whatever the disease condition, but including, of course, COVID. And the coordination mechanism to avoid the duplication. So this is something interesting. We participate in a project funded by Horizon 2020 called EU Response. And in this project, there is a work package 3, in fact, which is common with another project called Recover. And here we have the so-called trial coordination board. And we had the first meeting yesterday of this trial coordination board. And they were the PIs of 5 of the major trials, of solidarity, of recovery, of principle, of remap COVID, and discovery. And we describe let's say, the main characteristic of the trial, but most importantly, we describe what are the perspectives for the new arms or new therapeutic domain, in order to avoid the situation where 2 or 3 of them would open the same arm at the same time, meaning that it's important to optimize the use of resources, to optimize the use of patients, and to make sure that there is no duplication or overlap between the different projects. And in this trial coordination board, we also involve critical policymakers, meaning the people from the EMA, from the HTA, the CTFG, which is the Clinical Trial Facilitation Group, the ethics committee, the industry, and so on, in order to openly discuss what should be the strategy for the development of the new research question to be addressed in the project. And I think, yeah, this is the last slide. There are a lot of other issues that became obvious during this crisis. The first one is the critical role of equipoise in the conduct of clinical trials, meaning that a clinical trial can only occur if the investigator and the patient have the belief that that we don't know, that the chances of being cured are equivalent in both arms. As soon as there is a strong debate in the public media regarding, for instance, hydroxychloroquine, there are some patients who really believe that this drug is active and will never be able to sign the informed consent for participating in the trial. And the same is true for the investigators. Some investigators obviously believe that one drug was better than the standard of care, and they didn't dare to randomize the patient. So this is something very important. The second thing that was also mentioned earlier is the confusion between what can be deduced from observational versus interventional studies, meaning the interventional studies, randomized clinical trial, can lead to causal link between the intervention and the outcome, which is not the case for observational studies. And I was, for instance, very surprised to see that the steering committee of Solidarity decided to terminate the hydroxychloroquine arm based on an observational study that was published in the Lancet. Normally, they should not have done that because the observational study just provides some correlation but not causality. Secondary use of healthcare data. So this was also one of the buzzword in the recent months, meaning using real-world data to run clinical trials and so on. And here, I think it is the same study, the study published on the Lancet, the observational study published in the Lancet was based on data that were not verified, meaning that there was no source data verification and the quality of the data was very poor, and this paper should have never been published in the Lancet. And this goes to the next item, meaning the peer review of articles is something that is still strongly challenged in this crisis. There were papers published by signed by people who are also the editor of the journal failure in the peer review of the Lancet paper on this observational study. And I think this is let's say, an opportunity for us to really reconsider the whole ecosystem for scientific publication. The issue of preprints was mentioned also. I must say that personally, I'm very comfortable with the concept of preprints for basic research, because it means that the research will be then validated by the scientific community. You publish something on a preprint server and people can redo the experiment. For clinical trials, it's different for two reasons. The first one is that rerunning a clinical trials not only has a cost, but forces the patient to take risks, to take personal risks to participate in clinical trials. So we have to minimize the number of patients that are included in clinical trials. And the second thing is that clinical trials have an impact on political and regulatory decision. And I think it's impossible to just accept data coming from preprints. So I'm rather not comfortable with the concept of having clinical trials published on preprints. And the last issue is the data sharing, because it's mandatory to share the data. This was pushed forward. For instance, the European Commission decided to open a COVID-19 data hub, which is run by the EMBL EBI, but this includes, of course, all the viral sequences, the structural biology, and so on. But what is missing is now the instrument for clinical trial data sharing, because being compliant with the GDPR raised a lot of problems, and it is the reason why there is a new work package in a project called European Open Science Cloud Life, which is the life science component of this European Open Science Cloud, where we, together with other partners, will develop an instrument that will make it possible to share the clinical trial data on COVID in a GDPR compliant way. Thank you very much for your attention.
We thank you very much, Jack.
Yeah.
And
Thank
now we are a little bit delayed, but we have time because in closing, I am going to just say thank you, and I will let Thomas thank again. Actually, we have time. Our system is running, and we have really very interesting questions for all the speakers. So, but Gabriela has attracted the most of the questions regarding vaccine. I guess she scared everyone. But I will start with the kind of political and very typical Turkish question. The question was directed, I guess it was directed to Thomas, but to not let Thomas speak in the name of Turkish Health Authority, I will firstly direct this question to Ahmet Gül. Are you there? Ahmet? And maybe Atahan?
Yes, indeed.
Yeah, okay. Then the first question, I will ask Thomas as well, and whoever wants to comment on that. The question is, hydroxychloroquine trials are suspended due to safety concerns, but as far as we know, it is in Turkish MOH treatment protocol. How do you comment this?
Well, I mean, I cannot comment on behalf of the MOH, but it has been discussed among the scientific committee, and especially for the outpatients, we're still using hydroxychloroquine, very similar to the last comments about Thomas's interpretation about the preventive or post-exposure prophylaxis data. There is, I think, still a room about the efficacy of hydroxychloroquine. And usually in Turkey, we are replacing all this hydroxychloroquine arm with favipiravir generally, or we are favoring in combination. But I agree, for hospitalized patients, our current approach is favipiravir. And although there is still missing data about favipiravir, it seems it's so far effective. And regarding hydroxychloroquine, now a group of scientists from Turkey are preparing to publish their observation about the early phase success of hydroxychloroquine in terms of hospitalization rate and death tolls. So they will publish their own results. Of course, it's not something replacing the hospitalized patients' experience, but for the early patients, there is still a room. This is my belief.
Atahan, do you have anything to add? Okay, maybe I direct it to Thomas. Then afterwards, if someone needs to add something here.
Thank you, Professor Uzin. I think it's a great question. I think in the end, we can only restrict ourselves to the data that we have, to those facts that we can now rely on. And we have robust evidence from some trials that in patients who are hospitalized and severely ill, that hydroxychloroquine is not a reasonable strategy. But in many other settings, we do not yet have that evidence. For example, post-exposure or indeed pre-exposure prophylaxis, or in ambulatory patients that are less ill. And so in that setting, the question is currently unanswered. I think a separate discussion is whether the right thing then is to include an intervention that is unproven in a protocolized treatment plan, or whether indeed there should be focused then on assessing that treatment in randomized trials. Now, some trials are still ongoing and we will have some additional data, but I think we should make every possible effort to not use unproven treatments as part of standard care, but to randomize wherever that's possible. Where it's infeasible and there's a strong biological rationale, then there might be exceptions to that.
Thank you. I will move on with vaccine questions. Some repeat themselves. So do you have a pen, Gabriela? I will read them out, all of them, because the answers are common. The first is to Gabrielle. Recently, we read a paper related to a case. No, this is a later. Oh, okay. Yeah, it's okay. Recently, we read a paper related to a case who recovered from COVID-19, was reinfected many months, I guess 4 months later. I guess this is the first human reinfection. Protective antibodies are accepted to save us. So in this stage, do you think that vaccine-induced antibodies will disappear? Maybe some part of them who were vaccinated. Have you ever thought that if these kinds of cases count increase, what would your comments be? This is the first. I read it.
That's a good question, actually, because this is something which is not that much addressed. And I always address it because if you look at any vaccination developed ever in the world, this is very normal that you need several infections to have a long-lasting immune response. And this is also immunologically clear because you need mostly 3 injections. You prime, so the body gets in contact with the allergen first, then you boost, and normally the first antibodies are shown only after 6 weeks after the first injection. Then there is an affinity maturation of the antibodies, and for that reason, the antibody concentration must go down the next following 6 months, and then usually there is a third injection after about 8 months. And this third injection leads to the long-lasting immunity for several years. But actually, this is a question which has never been addressed enough, because, for instance, with the Oxford vaccine, the adenovirus-based vaccine, you cannot boost. You have 1 shot, 1 chance, and then you cannot boost, because in the same time where you develop antibodies against COVID, you also develop antibodies against the adenovirus. So with the boost, actually, you inactivate the vaccine. But this question has to be addressed. That's also one of the reasons, but again, I am conflicted why I think we should go for a conventional platform where we know that we can induce long-lasting antibodies. Mostly in the recent vaccination programs, you have to repeat it after 5 years or even after 10 years. Now the last recommendation for tetanus is even that you can stop when you are adult. But this is correct. And the thing with the reinfection is also a good question, because what we know up to now, in fact, is that with the natural infection, especially when you had a mild infection with COVID, it is possible that after a few months, let's say 4 or 6, we don't know, that the antibody titers go down, because as I said, the natural course of the corona is kind of this escape mechanism that the antibodies are not built in high concentration. And this is one of the reasons we think that is because the spikes are in a low density. But in a vaccine with a conventional method, you have a very dense spike concentration. So the antibody titer probably with the vaccine is higher and probably long lasting, but not forever, as I said before.
Oh, okay, let me continue. To Gabriela again, what is the actual statement about vaccine development? I mean, how much vaccines have been actually developed? Actually, you have answered those questions. By who? Yes. And based on what? How it's supposed to work? And probably when first vaccinations will be effective?
I think I showed the numbers. It's about 135 in preclinical, and then it goes down, and it's about 15 to 30 in clinical development. 2 are on the market, but let's say they are on the market in China and in Russia, they probably would not get marketing approval in other countries.
Is it really possible to develop vaccines in this very short time frame due to the urgency of crisis? Are we neglecting possible side effects?
Yes, we are. And I thank this person for this question, because if you read carefully the papers of the phase 1 studies, and not only the abstract and the press releases of the companies, but also the appendices of the systematic side effects, you see that there are major problems. These vaccines, they have side effects, and we really have to think about what we do. And this is a good question. We don't know these technologies, and we see that there are side effects. There are 2 companies that had to take away their highest dose, even if the highest dose showed the best immunological results, but because of side effects, they had to go for 1 dose lower.
Everybody, did you notice the commercial on the left corner down? There was a subliminary message on Turkish coffee. Have you seen that?
No.
Ahmet Gül implanted some commercials for Turkish coffee. Now,
I couldn't get it.
You had coffee, man. Everyone saw that. It was obviously Turkish coffee. So,
Sorry about it.
for everyone, dear all, and Gabrielle answered that question in her presentation, so I will spare her. Dear all, what do you think of herd immunity concept compared to vaccines? Gabrielle said, don't count on it.
I mean, herd immunity is no option. This coronavirus is a very dangerous virus. It affects, I mean, you die from corona, not with corona. I think this is the essential sentence. It's not just a flu, it's a dangerous virus, and there is no option for herd immunity. The lethality is much, much too high. No way of herd immunity.
Can I maybe add to that? I would just echo Gabriella's words, but I think it's dangerous when we get to a position where we talk about herd immunity rather than considering the risks to an individual. And there are many groups in our societies that are extremely vulnerable to this infection, where the mortality is 1 in 4 in some patient populations. And you're arguing something that is unproven, and in fact where the evidence is the opposite, and trying to rely on that and not taking every possible step to protect the vulnerable members of our society is really perilous and slippery ground that we shouldn't venture onto.
Okay. Anything else?
Yes.
Yeah.
I want to add something about the first question you asked to Gabriella, and then maybe we can continue on the same topic in a different way. Well, as you mentioned, there are differences in the clinical courses in patients, and some patients are really running either a very mild course or they are asymptomatic. And for the case you mentioned who got a second infection, well, his first infection was quite mild, and even the so-called second one is quite mild. So we know that in mild cases, the immunity is probably much milder and short duration. And the chance of getting another infection is probably higher than other people, but the course of the disease is also, again, quite mild. So when we are talking about a disease, and it can be induced either sort of mild infection or even vaccination. If in the chance of being infected and when you are infected, having a milder course is higher compared to other options. Well, it's not a bad thing. I mean, you may have vaccinated, vaccine may not be 100% successful, the chance of being infected may not be reduced totally, but if you are having a mild infection, the only risk might be a temporary risk for other people to get other people infected. Otherwise, in terms of individual level, having a mild infection is somehow desirable, if it is possible. I mean, this is the aim of the treatment or even vaccination. So in this context, well, we are usually ignoring the cellular immunity part. We are usually measuring the efficacy of a vaccine based on neutralizing antibodies. But when we check the individual with asymptomatic course, probably it's more associated with their cellular immunity rather than having neutralizing antibodies. So antibody development is, of course, a very good thing, but there is a potential of inducing antibody-dependent enhancement depending on the induction of Th1 or Th2 type of immunity. So in some of the vaccinations, there is this risk. And what measures or what methods can be used to detect the potential of antibody-dependent enhancement and to prevent it in vaccine development?
This is an important question. So, to our opinion, the risk of to reduce antibody-dependent enhancement is that your antigen you vaccinate is very small, the smallest possible. So actually, just the few epitopes that really bind to the receptor binding domain, let's say just the receptor binding domain and not the whole S1 spike. As soon as you have a bigger molecule, you have a lot of rubbish antibodies you actually don't need for the protection. And then there's the possibility to really to get this antibody-dependent enhancement. And the other thing about the T-cell story is important. I think one of the goals of, let's say, for instance, virus-like particles, that's the technique I know the best, is that you try to induce only the B-cell part. The antibody, only the antibodies without touching the T-cell system, because there is also a cell-dependent a cell-dependent enhancement as side effect for the vaccination. So to escape the T-cell response and go directly to the activation of the plasma cells, this would be kind of the goal, and in a very specific way. This would be the optimal vaccine.
May I say something? I'm very afraid of complications like post-vaccinal encephalomyelitis or acute demyelinating polyneuropathy after vaccines, which after mass immunization could create a major health problem too. What do you think?
I share this concern because I am not a neurologist, but I thought about it. If you have a look at the phase 1 data of the trials, you see that one of the most side effects and the highest level, like people report, is fatigue. And fatigue for me clearly is a neurological system. That really means that the vaccine definitely has some also like neurological systematic effects, and we know from previous other vaccine trials and developments, not about COVID, that in fact this is possible, and this is a fear also we have, and it has also to do probably with the T-cell responses, with the pro-inflammatory status. Maybe even when you're vaccinated and then you get an infection, that you overreact. I share this concern, but we will see. I mean, there's no option. We have to go for it, and maybe I don't want to come over too critical. I am very much in favor of vaccinations, but we have to be careful.
Okay, with the vaccines, there are a couple of other questions, but there is another you have answered already, but you might like to repeat. Hi there, are various announced vaccines efforts currently developed at different stages? If one or some succeed, is it possible to develop millions, if not billions, of vaccines in a very short time frame? You answered that actually, and you gave the example with the planes and so on.
Yeah, but this is a very good question. I mean, the reason why the mRNA and the adenoviruses are so fast is simply because they received the genetic information from China in December, and this is a synthetic process. You just put all the molecules in the machine, and at the end of the day, you have a GMP S1, and you put it into this stuff. It's need other goods. It's a very complicated process, and if you have to produce billions available worldwide to produce RNA, this is actually an important question, and that's the reason why for the companies the doses are very, very important. BioNTech, for instance, had a first dose 1 milligram, 10 milligram, 30 and 100. So imagine if they go for the 100, they need 100 times more vaccinate products. So now they're going with 30. But these questions are very important for the supply, for the development.
Okay, there's a question for me, but I will share that with actually Britta answered this question very nicely, and with Chuck. Dear Yağız and esteemed speakers, this is you. Thank you for this wonderful webinar. What is the actual limit of stretching limits of ethics and protocols under this pandemic with concept of grace under pressure? Well, my answer is there is no such thing as stretching the limit of the ethics, but expanding views. Like, you know, this German experiment in the concert. If at the first look, you see this as a breach of ethics. Some of us even compared this with Tuskegee trial, etc. But if you look closer, actually, you might find a space for, this is not bending, stretching, but expanding it. Actually, you can read, there are ethics articles on this challenge studies. Even there you can find reasons, but I'm not going to discuss this. But I want to say something about negative results. A negative results is actually a proven, it's an evidence. It's a result from a perfectly performed study. There you can have negative result. The problem is we don't have negative, we have many studies with no results, actually. But the problem is with negative things like this repeating infection thing and the power of virus, etc. If you have some hint, some outcome on a negative thing, you question it less. You know, you tend to believe to negative findings, not negative proven results. I forgot to mention this. I wanted to mention it. Looking at your faces, I did not see any expressions, and I drew that I could not express this clearly. But you know, we have with Ahmet such kind of relations. He explains always what I say, so I expect him to explain it. But going back to the question, Britta, what is the actual limit of stretching ethics and protocols?
I think I would agree with you that there is no stretching. I think our first concern always should be the safety of the people we are including in trials. And planning these trials, we always should do a careful risk balancing or risk calculation of harms and benefits, including these people in our trials by a systematic way, and being more on the serious and concerned side about the safety than on the other side.
Thank you. Jack, actually, you talked about different new designs and opportunities, but you did not talk about stretching ethics and so on. Your sound is off. We don't hear you. You must.
Oh,
yes.
Sorry. So there is a link, because when the trial is poorly designed, and especially when the trial is designed in a way that it will be impossible to reach the statistical power and to give an answer, this is not ethical, because the patient will take risk to participate in the trial, and the trial will not give any conclusion. So this is the first thing. The second one is that, you know, there were an expedited review by the competent authority and the ethics committee to boost the approval of the trial, and this worked very well. And this is also the demonstration that the ethics committee and the national competent authority can work faster than usual. So it's good to know. But there is something that is a bit surprising, that all these trials on repurposing drug for COVID were accepted by ethics committee and competent authority without preclinical argument. There was no animal experiments and so on. Now it's possible because there are some mouse model, there are some monkeys model, but still it's surprising, because for any other product, when you want to, for instance, to repurpose a drug that is already on the market for rare disease or for rare cancer and so on, people ask as far as possible for preclinical data. But here the ethics committee just forgot the preclinical data.
Well, there are many questions. There is an address. There are questions for Ahmet, for Betül, and so on. I am going on. Dear Ahmet, you talked about our findings in 6 months regarding COVID-19. Is this possibly the fastest learning curve in healthcare history?
Well, I really don't know. I mean, we have a learning curve. Well, in each country, depending on their own experience, they had a different curve, I believe, because in addition to the published data, we got a lot of information from our patients. So the patient follow-up is much more informative and educative than reading papers. Well, I think there are still a lot we have to learn, but we have just started to recognize the disease course features. Of course, there are still some newly described manifestations of the disease, but more or less, we have now bad prognostic factors and the drugs that are working and that are not. And we are now much more confident about the management of the cases, but still we have lots of lacking information about the efficacy of many other measures and unexpected disease courses. I think compared to previous pandemics, the course of these pandemics is probably much better than, let's say, Spanish flu or the course we observed in SARS, MERS, or let's say in HIV. But it could be much better.
Thank you. Gabriela has to leave. She wrote me, but there is one last question regarding vaccine. Do you see necessary of healthcare industry on vaccine development? I read this as well. Is healthcare industry necessary for vaccine development?
Yes, I had a very interesting discussion last week with the head of our scientific Corona task force at the Ministry of Health. And I think this is one of the major points we have never seen up to now. We are at a point where the projects need the support of their national ministries. We can't do it alone. Academic is out anyway because they have any money at all, but also the industries. they can't do it alone. So this is my personal opinion. Yes, what we have seen now, all projects that are in phase 3, they got enormous help of their health ministries. Without, it's not possible.
Okay, and thank you for joining us. It was a
Thank
pleasure.
you for the invitation. Sorry, I have to leave. Thank
well, I
you
have
all.
other questions for others. I will
Okay.
continue until everyone leaves. Okay. Now, dear Betül Baykan, what are the possible routes to speed up research in these extraordinary times without sacrificing health of researchers?
We have to take all kind of preventive measures, all kind of developed personal protective equipments, and we have to sometimes lower the research rates. I mean, it's in other areas, that's true, but that's what have we done. We have speed up with COVID research, but so I can't say anymore. So we have to protect ourselves first and go on to work.
Of course, there is a recent announcement of, again, this physicians' chamber. I expected actually the chairperson of Istanbul Physicians Chamber joining this meeting, because she's in our ethics committee. If she hears us, she can write me a message through WhatsApp. Okay, I'm going on. Actually, there is one other Betül question. Where is this? Let me first thank all speakers. Dear Betül Baykan, why do you think the first of symptoms of COVID is related to neurology, even though it is regarded as a respiratory disease?
No, I don't think so. This is not true.
Okay.
I don't think so. I'm a neurologist, so my examples was based on neurology. These are only examples to give you an insight on research-related problems, and also research-related and also clinical-based problems. I'm a neurologist.
Okay, I continue with addressed questions. There are general questions. Dear Britta Lang, do you see mutation of virus which leads to dramatic changes of evidence slowing development process?
I don't think that I'm an expert on this topic, but I think what we see is the reflection of this developing virus in the publication flood. This will be quite interesting. So what the flood will be next year after all these subtypes are then maybe examined. Or was this the question? I'm not sure.
Any other comment on this? Okay, then there is a Jack question. Dear Jack, you know, I love this sincerity. We are among friends. Although Thomas keeps me addressing Professor Üresin, I don't know why. Maybe there is a Cambridge rule for that. I don't know.
Well, it's difficult to pronounce Yağız, you know.
He pronounced my name very much after a couple of beers. I know that. But anyway, this is out of the scope of this meeting. So, dear Jack, does European Union common development practices and sharing culture help European academy/industry foster better COVID-19 clinical research?
Yes, I can say yes, because you know, there were some funding lines for COVID research, for COVID treatment. There is a project funded by IMI, by Innovative Medicine Initiative, called CARE. I don't remember exactly what is the meaning of this acronym, but CARE is a project that was just funded recently, and it's about developing a new therapeutic solution, either through repurposing based on the the high throughput screening of chemical libraries, or the development of new innovative small molecules, and also the development of new monoclonal antibodies neutralizing some specific part of the virus. And then once the development will be completed, all this drug will be tested in multi-arm clinical trials. So there is a consistent policy. I think the reactiveness of the European Commission was a bit slow, because like all the big animals, it's difficult and so the country were very fast to open call and to fund research on COVID. But now there is clearly a European policy in developing new drug and testing new treatments for COVID.
Thank you. And I'm sorry for not looking very concentrated, because I have to read all the questions. Now we are turning to the data stuff, but there was something. Okay, I will come there. Dear old, do you think there will be a major and rapid mandatory shift and change to digitalization of clinical trials? If so, is it possible or even doable?
I think this is a question that I mentioned during my talk, meaning that there was a clinical study, not a clinical trial, an observational study run based on hospital data, on healthcare data, and it turns out that part of this healthcare data was just non-existing data. And this is a major threat. It means that it's possible, of course, to run clinical trials based on hospital data, but this means that there is a need to harmonize the collection of data, the data standard, the data format, to be able to tackle all the aspects of security and confidentiality and GDPR compliance, which is a very difficult exercise. There are some teams working on this, but there is a need to follow the same rule as for classical clinical trial, meaning having the data quality control with source data verification and with traceability of the changes. And unless we have this, the quality of the healthcare data is now far too low to be acceptable for clinical trials.
Well, I would like to mention the IMI, Innovation Medicines Initiative project, EDEN.
Yeah.
European Health Data Evidence Network, and we had the chance to be part of that in the COVID part, and we started just restricted to COVID data, and we really realized how difficult it is and how multi-sided it is. You know, there are many questions on data. It's very nice to dream about using data, and that data shows. Gives the answers, but it's very difficult to be sure that the data is the data you think it is. And so there are other questions related to that, and I would like to have your ideas on it. Sorry. Again, it's data. Thank you for this wonderful event. Do you think cross-national data sharing will speed up common vaccine development or any treatment development actually? Is there any specific obstacles regarding different genes? This is vaccine. Gabriela left. Thomas.
I won't comment on vaccine development, as that's not my field of expertise. But in terms of international data sharing, I think there is much enthusiasm for doing that, but there are many obstacles. And when Jack was just answering, I was thinking about the problems we face in trials with using routinely collected healthcare data that is disparate between jurisdictions. So in some countries or regions, there are very high quality data sets. Those data sets are dissimilar between countries. And so the simple, if you're doing a registry trial, for example, with all-cause mortality or hospitalization as an outcome, the data that you can get in one country might not be the same as the data you can get in another country, and that makes actually international trials that use routinely collected data very difficult, and is a hurdle that we're not very close, I don't think, to overcoming. But there are multiple initiatives to try and be collaborative and to share data across jurisdictions. We're a long way from being able to do that freely, but there's certainly a lot of effort in that area.
Thanks. These questions are again related to what Jack has presented. There are two questions. One is, can you summarize ideal load sharing between academia, industry, and regulatory authorities on COVID-19? And in an ideal world for fast progress, which party of healthcare should lead pandemic management efforts? Universities, industry, or regulatory bodies? Thank you.
Difficult, very difficult question. I think there are different models in different countries. For instance, there is I don't remember exactly the name of this board in the UK, but there is a UK board to let's say to drive the research strategy in the COVID crisis, where the chief medical officer, where the chair of the NIHR are sitting. So there are different stakeholders, and they are able to make strategic decisions. And this was missing. In many of the other European countries. And this is probably one of the reasons why the UK was able to develop successful trials like the recovery trial that until now has enrolled, I think, 11 or 12,000 patients in 172 or 3 sites, meaning that there was a strong recommendation to test 5 drugs, and then to open new arms. And at the same time, there was a letter sent to all the practitioners in the United Kingdom saying, okay, you should enroll patient in recovery for the patient in the hospital ward, in principle for the outpatient, and in remap cap for people in the intensive care unit, and so on. So this recommendation and this top-down strategic decision is a very good example of what should be done. And then for the first question, it's rather something related to what I described by the trial coordination board, meaning that in this trial coordination board, they are the PIs of the trial, but they are not the one who should decide what are the new arms to be open. This should be discussed with the HTA, because they are the one who have not only the knowledge, but the understanding of what are the priorities for the society. With the EMA, what is possible in terms of registration trial or not, with the National Competent Authority, with Ethics Committee, and so on. And all this should be discussed. It doesn't mean that the decision should result from a vote, but there should be, let's say, a real dialogue in order to make the right decision on what are the research questions that have to be addressed in these trials.
Thank you. There is one other question. Afterwards, I will move to the closing, but I would like to hear the opinions of Britta and Thomas again about this data sharing and data stuff. Data, clinical research, policy.
From my perspective, I think one of the big obstacles for data sharing is data protection, and the dissimilar policies and guidelines and regulations in the countries on data protection. So we had wide discussions here if we like to share data, when is data really anonymized, so then can it be used? And also, of course, what Thomas already said, the non-similarity of data sets. I think these are the 2 huge obstacles to the quite good idea of data sharing.
Thomas?
I think that the final comment I would make on that is maybe a perspective from the UK that feeds into also the questions on ethics earlier, where there are very detailed data sets within the NHS that can be used for research, and the bar is very high to access those data under normal circumstances. And along with, as Jacques alluded to, urgent public health committee that prioritized trials and other research studies in the UK in a top-down, fairly autocratic manner, but very effectively so. There was also a temporary measure introduced by government that would allow those studies that were prioritized to have direct access to data sets that are normally part of the public health infrastructure and the NHS infrastructure that facilitated the process very rapidly. And so there's a public interest versus the individual's data protection interest balance to be struck, and those rules were slightly amended in the heat of the first wave of the pandemic. That central permission expires, I think, in October, and it remains to be seen how that's going to be dealt with. But there are different ways of approaching this, and that was the UK's way was actually a fairly autocratic, centralised system, which worked well under the circumstances, but is not everyone's view of how things should be run.
Great. Okay, there is one comment. There is one scary question. The scary question is, do you see or anticipate similar patterns of COVID-19 versus Spanish flu? Shall we anticipate harsh second wave? Ahmet is going to answer.
To be honest, I hope we will not. Well, I think there will be a comeback, definitely, depending on the circumstances in the winter season. But the system would be much more prepared, and it would not be the same one as the Spanish flu. I think compared to Spanish flu course, if you look at the course of the disease, the mortality rates, I think after 100 years, we are much more advanced situation now. So I think there will be a comeback, but it would not be a very big one. And I hope in the meantime, we will have much more effective treatment options, and hopefully maybe one of the vaccines or one or two of the vaccines would be available.
Okay, there is one question about Swedish herd immunity, but this has been answered. Would you like to add something, Thomas? But I guess you have answered that.
Well, yes, as a last point, I want to add one thing about the digital data that was discussed previously. I have to leave anyway, but regarding the digital data, my worry is about the one extreme of the using digital data, which is the patient-described description of all manifestations or outcomes, etc. You know, it is possible to use all digital data, hospital-based data, whenever you check it. But we have observed some studies, as I mentioned about one of the hydroxychloroquine studies. Most of the data were collected by telephone interviews, the patient description, even the disease state and the outcome was described by patient. I think that's the worst part of the digital data. I think this is something we have to avoid. Otherwise, there will be a change to use much more digital data, to use all available hospital-based information. But if it comes to another end, there are some worries.
Okay, don't leave. We are moving to the end. Let me read the last comment. Let me thank all speakers for kind presentations and their efforts on this pandemic. In today's technology advancements, there has been a flood of data and knowledge. With respect to the topic of the webinar, how can we identify reliable knowledge in the middle of infodemics? Can we or should we control knowledge management, not for the sake of restriction, but for the sake of increasing quality of knowledge? I will leave this hanging, actually, if no one wants to comment on that. This has been actually kind of a summary, but I have two informations to give you. One is we have had over 2,000 participants in this meeting. And I would like to thank you.
2,000.
2,000.
A good number.
Turkish lira. It's 2000. And I would like to announce there has been a recording of this meeting, and the recording will be for those who could not listen to watch all the event. It will be there for another 1 week in the same link, and afterwards we will load this up to Istanbul Medical Faculty's YouTube channel. I will send you the link. And with that, I would give to the chairperson of ICN, Thomas, a concluding remark, and then I will say thank you.
Thank you.
Thank you very much. Guys, it's been a terrific day of very stimulating talks and clearly many challenges that we still face, but hopefully with some direction as to how we can best approach those. I would also, from my side, just like to thank Yais and the Dr. Club team for the organization. It's been a meeting that's run very smoothly. I recognize it requires a lot of work behind the scenes. We're very grateful to you all for that. I'd also like to thank all the speakers once again for very stimulating and thoughtful presentations. And finally, also the attendees for some very stimulating questions. It's been an enjoyable and challenging discussion, very much appreciated. So with that, thank you very much, and I'll hand back to Yais.
Okay, I just will echo Thomas. I thank you all, and to all the participants and Dr. Club and ICN, and to my university, which let me sit on the Vice Dean's chair. And I would like to thank again in the person of Jack to Ekrin, and I would like to thank to Doctors Club. Thank you and good evening.
Thank you. Bye-bye.
Thank you. Bye.
Bye.